Morning, sir.
Morning, Dr. Anand.
Yes. Good morning, ma'am. Himani, ma'am. Your audio is moved.
Good morning. Yeah. Technically challenged, I felt today.
Yeah. Sometimes that certain things we cannot do.
Yeah.
Okay, ma'am. We can manage it. Ma'am, people are joining only, so we'll wait for another couple of minutes and then I think
Yeah.
we need around 45 participants are there.
Sure, we'll wait.
Wait.
Good morning. Hello. Good morning, Dr. Anand.
Good morning, sir. Good morning, sir.
How are you?
All good, guys. All good, sir.
Well, sir, good morning.
Good morning. Good morning. So it's 9 o'clock. Maybe 2 more minutes we can wait.
Yeah.
I'll just text in the group that we are live now. I have texted in the group that we are live now. Maybe in a minute or two, people will join. Or otherwise, we can start anytime after 9 or 2.
And okay, fine, sir.
Yeah. Dr. Anandraj, I think we should start now.
Okay, sir. Okay. So, very good morning to all, and welcome to the second day of our online course. That is, we have total of 2 sessions today. That is 3 lectures in the morning and 3 lectures in the afternoon. So, I welcome you all to this program. I know it's a little hectic to look onto the screen and listen to for a long time, but we have to. And I request all the participants to please, if you have any queries or anything, please rise in the chat box so that the speaker can answer to it and make utilize of this particular platform, because we are having speakers across the country, and that too the elite and eminent speakers in this particular field. So make use of this opportunity well by asking questions and make it more interactive. So with this, let's start with our first session, that is by Dr. Himani Khanna on the medical aspect of intellectual and developmental disabilities, autism spectrum disorder, and attention deficit hyperactive disorder. And this session will be moderated by Dr. Madhu K. and Dr. Indira MD. Ma'am will join shortly. Because of some technical issues, she is not able to join.
Sir, I have joined in, sir.
Yeah, okay.
Good morning, sir. I have joined in, sir.
Thank you, ma'am, and welcome. Dr. Madhu is professor and head of the Department of Pediatric and Preventive Dentistry, KLE Society of Institute of Dental Science, Bangalore. Has completed BDS from Kempu University in 1996 and MDS from Rajiv Gandhi University of Health Sciences in 2001. Holds over 25 years of academic experience in pediatric dentistry and teaching, and served as ISPPD as Executive Committee member for 3 terms and Vice President in 2024 to 2025. Authored 30 plus national and international scientific publications. We welcome you, sir.
Thank you, Dr. Anand.
Dr. Indira MD completed BDS in 2003 and MDS in 2009 from JSS College of Dental Sciences, Mysuru. Earned her PhD in 2018 from JSS Academy of Higher Education and Research. Recipient of Distinguished Human Award by ISPPD in 2024. Awarded the Ben Magnuson Bright Future Award by IAPD in 2021, and received fellowship from the International College of Dentists in 2017. We welcome you, ma'am.
Thank you, sir.
So, over to Madhu sir to introduce our speaker.
So it's my good morning, everyone. So thank you for the invite. So it's my privilege to introduce Dr. Himani Anulla Khanna. So Dr. Himani Anulla Khanna is a developmental behavioral pediatrician, entrepreneur, and adolescent mental health expert with extensive clinical and academic experience. She is a co-founder and director of Continue Kids and trustee of Continua Kids Foundation, supporting child health and education initiatives. She serves as visiting consultant, a developmental pediatrician at Madhukar Rainbow Children's Hospital, CK Birla Hospital, and Paras Hospital, Gurgaon. Holds MBBS, DCH, PG, DDM qualifications, and is a PhD scholar in public health at Jamia Hamdard University. He is an avid blogger and advisor, parenting platform, also a member of ethics presentation awards and presented at national and international conferences. He is a life member of IAP, NCDP, AHA, GDBP, IDPA, and holds leadership roles and received Women Disruptors Award for Entrepreneurship Excellence recently. So we welcome you, madam.
Thank you. Thank you so much for that kind introduction. Yeah. Thank you so much, Dr. Madhu, for that kind introduction. I'm very grateful and thankful to the Academy who has given me an opportunity to speak on my favorite topic today. And without wasting time, I think we can start the presentation. Can I share my slides?
Sure, ma'am.
Yes, you are the co-host, Dr. Imani. You can do that.
Okay. Let me make it as, yeah. Is it visible? Well visible? Sorry. Oh, not sure how it is moving. Yeah. Okay. So I believe we are all ready now for the day of a lot of academic input, and we are all charged up for that. And I believe topics like neurodevelopmental disorder may not be usual for the pediatric dentist, but yeah, it holds a lot of importance because as pediatric dentist, we as behavioral pediatricians feel very confident when we are sending our child for dental care to the pediatric dentist because we know that they will know the small nuances. And personally, I do not prefer sending my children to general dentist, but I prefer sending my children to pediatric dentist because it gives me a lot of confidence there that they will be able to manage my child with neurodevelopmental disorders with more precision. So, starting with neurodevelopmental disorders in dental practice, how they can affect and what all we can change or know to increase or improve the care that we are going to give to our child. So, most common neurodevelopmental disorders are autism spectrum disorder and attention deficit hyperactivity disorder. And here we will go through etiology, diagnosis, what are the comorbidities, what are some of the behavioral considerations, and how interdisciplinary care can help. So, okay. So our today's learning objectives would be we'll first try and understand what is the etiology, why these neurodevelopmental concerns are happening, and then we'll go a bit into the diagnostic criteria so that you people understand what are the symptomatology like, how we classify them in a scientific manner, and then we'll recognize the comorbidities because identifying systemic and medical conditions which are associated with these neurodevelopmental disorders help us to plan our further course of treatment as well. And then we'll identify what are the behavioral and sensory issues because these are the main symptoms, main concerns which interfere or which can impact the dental care delivery for the child. So then we'll go into the medical management protocols, how we manage and what is the behavior management techniques. And lastly, we'll talk about early and interdisciplinary care and what is the role of early intervention, interdisciplinary care, and how we all can collaborate as healthcare professionals to impart that. Then let us understand what are neurodevelopmental disorders first. So, neurodevelopmental disorders, as per DSM-5, are a group of conditions which are originating in early developmental period, that is before the school age, and they cause impairment in the child's personal, social, academic, or everyday occupational functioning. So why we want to talk about them? Because the magnitude of the challenge that we are coming up across or the prevalence of these conditions is significantly high, and that is why it's important for us to know what is the what are these conditions and how we can manage them together. So, about 10 to 18% children, or you can say one in every eighth child, roughly 12% it accounts to, is affected with at least one neurodevelopmental disorder or the other. And what are these neurodevelopmental disorders? They are intellectual disabilities, attention deficit, hyperactivity disorder, speech and language disorder, and then the autism spectrum disorder, and specific learning difficulties, where we also include dyslexia, dysgraphia, dyscalculia, and those kinds of disabilities. So, yes, these are some of the common, but the Prevalence is so high, and this is as per the research which was published in PLOS in 2017. It was an Inclin Trust research conducted by Inclin Trust, and it's quite an extensive research across 5 different states, and a good number of sample size was included here. So this is Indian data, which says 1 in every 8th child has some neurodevelopmental disorder. So we'll come to the common ones that you and me come across in our everyday practice more often. So one of them is autism spectrum disorder. So understanding now what is autism spectrum and why it is happening, because everybody says that the prevalence is rising. Okay, earlier the prevalence was 1 in 65, then got down to 1 in 54, and now currently CDC international data says it's 1 in 33 children. And although the Indian statistics and prevalence says that only 1% of our pediatric population, 1 out of 100, that means, is on autism spectrum. But this is again a data which was published in 2017 and before COVID data. If we do a reanalysis, maybe a recheck on the prevalence, we may find much more prevalence in today's time. Uh, so, uh, uh, for when we talk about autism spectrum disorder, it is a multifactorial neurodevelopmental condition, and no single cause so far has been identified here. So, the origin, the etiology is mostly epigenetic. When we say epigenetic, that means there are some genetic factors where the chances of a child inheriting it from one of the parent is very high. There are certain specific genetic mutations also identified here. But when I say epigenetic, it is a genetic phenotype which, when exposed to environmental factors, which are risk factors, put together, they increase the chances of a child having autism spectrum. So that is environment modifying our genetics. So that is how the etiology is thought of and is shown. So there are certain neurobiological factors also, because whatever the research has been done, it demonstrates some amount of atypical connectivity or default um neuronal networks, the cortical organization, pruning. Then there's some neurotransmitter imbalance also, dysregulated serotonin dopaminergic signaling is also observed. So there are multiple factors, but what are in our control is the environmental factors. So knowing about them and advocating the right environment is very, very important. uh, about the environmental factors: increased parental age, prenatal exposure to valproate, if the mother is had any seizure disorder during pregnancy, if there's some maternal concerns and the mother is given anticonvulsant, then maternal infections, perinatal complications, all these, they are increasing the risk. So the risk is because of multiple factor. Even increased father's age, paternal age, increases the risk. So there are multiple factors in the environment, and when we talk of environment, it is not just related to prenatal, antenatal, or postnatal. It is also the environment that the child is experiencing after birth. Because autism, there is one kind of autism which is infantile, like it starts right from the time that the child is born. But many a times the parents would report that till 18 months my child was all right, and then between 18 months to 24 months they experience some amount of regression in their milestones, and then the child who was responding to uh, the social interaction or the name call has suddenly started deteriorating, the word count has reduced. So this is also, there is also some amount of regression seen by the parents. But a lot of time there is a misconception, a huge myth that is it the vaccination which is causing it? No, it's not the vaccine, because there is adequate amount of research done and published, which gives adequate scientific evidence that vaccines has no causal link to autism. So that's a very big myth that I think confidently you can tell the parent, go for vaccination, because it prevents your child from a dangerous infection. And it actually, that has its own, if measles vaccines is not given, a lot of parents have this myth, then measles related encephalitis is more life threatening. So there, this myth has to be busted by every professional. then yes, the male is to female ratio is again 4:1. The males are at more risk than the female child to be on autism, and that also and in twins also they have observed that if one child is on autism, the risk of the second twin or the risk of the sibling getting autism are higher than in the neurotypical scenario. So these are all giving us clues towards genetic predisposition or genetic connection, while there are a lot of environmental factors which contribute to the etiology. Some environmental factors also come into play when there are nuclear families, the engagement with the child is less, extensive amount of screen watching is there when the child is supposed to socialize and talk and interact. At that time, the child is sitting in front of the screens for a very long duration, like 3, 5, 6 hours at times, and both parents are working, no support system at the back end. The child is small. As a result, the child is not being engaged adequately and lands up in front of the screen. So those kinds of factors can also play an important role in triggering it. Again, environmental factor. A genetic phenotype is getting triggered with all these environmental factors. Then how do we diagnose them? So there are few things that we can keep in mind. And not everybody is supposed to diagnose, but at least picking up some red flags can be very, very important. Red flags can start appearing as early as 1 year, 6 months also, but maybe for a dental pediatric dentist, it may be difficult to pick some red flags, but you can know some simple 5, 6 milestones between 18 months to 2 year. If the child is not showing those milestones or he's not demonstrating that kind of interaction, it calls for attention and a detailed evaluation. So those would be at 18 months, the child would speak at least 4 to 5 meaningful words like mama, papa, dudu, mamam, these kinds of words the child starts speaking at 18 months. The child will have very good non-verbal, that means gestural communication. Gestural communication, when I say, I mean that if the child wants something but does not have a word for it, the child will use their index finger to point at that particular object and then look at the parent. So joint attention plus pointing. So this kind of a non-verbal communication starts at 18 months, and this milestone is fully developed by 18 months. If you don't find it in the child, it calls for attention, it calls for a detailed evaluation, and making an eye contact, responding to the name call. Child starts responding to name as early as 1 year of their age, and if at 18 months also the child is not responding to the name call, we definitely need to investigate what is happening. So these are some of the red flags that you can keep in mind, and observing the child's behavior is important than just asking, because parents at times are not able to relate, and they are also in a stage of okay ठीक हो जाएगा, we can wait. कुछ सब बच्चे अलग अलग तरीके से develop होते हैं, but if you find any of these features which are in a very young child as early as 18 months or 2 years, then must seek that opportunity to tell the parent or ask the parent to seek for a special opinion. Then coming to the diagnostic criteria. So here, when we have to look into a little more into the detail of is the child actually on autism or not, there are two major domains that we need to consider. The first domain is social communication and interaction. So social communication delays, how do we explain them now? So there will be deficit in social emotional reciprocity. That means abnormal social approach. The child will not look at you, the child will not interact with you. You'll try to say hello, the child does not understand, will either give a blank look or will turn the face around or will try to cling to the mother, and at no stage will try to reciprocate anything. If you give a toy or something which is interesting, you will not be able to grab the child's attention, and the child is non-responsive in a way. And after some time, when you start talking to the parent, you will find the child getting engaged in some object and is not really bothered about what is happening in the environment, and will be totally disconnected, and there will be no bye-bye, there will be no greetings, no interaction, no smile, or fearful response, because generally children get scared when they reach the doctor. So that kind of a social emotional reciprocity will be absent, and you will not be able to appreciate a normal typical response there. Then there will be impaired non-verbal communication, as I already spoke about the gestures. So there will be absence of eye contact, the gestures like pointing, sharing, showing their toy. If you give them a car or a teddy bear in your clinic, and then the child shows it to the mother, oh, see what I've got, that kind of a sharing will be absent. And the facial expressions will also be able to tell you that the child is not understanding or gauging what you're trying to ask. Many a time, if a child is a little grown up, you ask them, what's your name, beta? Then the child will say, what's your name? Instead of being able to respond, answer, understand, comprehend language, they will tend to repeat it. Or they may just be mum and will look at you as if they have not understood anything. So there will be difficulty in maintaining relationship appropriate to developmental age. Like if you poke in a little and ask how is he, does he have friends, does he go to play school or school, and so the parents will report he does not interact, doctor, he's a bit shy, he does not interact with adults. Then if you dig in a little more, what about peer? Then they'll also say, oh, he doesn't have too many friends, he does not like to play with other children, he's very shy and he's reserved and he's to himself. So that may sometimes be very all right and normal for the parent, but actually it could be a cause of concern, and we need to look more into other symptoms. So the second domain is restricted repetitive patterns of interest, behavior, and activities. When I say interest, behavior, activity, then there could be a repetitive physical movement like flapping their hands, spinning around, or there could be some play where putting water in one to the other, repeatedly doing the same task again and again. And some children, they will have repetition in the speech where may not find them going round and round or doing flapping, hand flapping, or any other repetitive task, that you will have to dig in the history to find out if the parent is reporting something like that. But in speech, the child will not comprehend we are saying. Many a child times the child will be repeating whatever we are asking them, or will just keep on repeating something else that the child has heard at some other time. So we call it as echolalia. Echolalia could be immediately if I ask what's your name, and the child will repeat what is your name. And sometimes it could be delayed echolalia, where the child is trying to repeat some dialogue from a TV ad, or some dialogue that he's heard in school from the teacher, or some rhyme that he has memorized from screen, and is constantly going on humming or singing that. And many a times there will be lack of clarity also of what they're speaking, and more occupied in objects than in human interaction. So that is the kind of stereotypic motor or verbal speech related repetitive behaviors you can observe in children. Then there will be insistence of sameness. Many times we get children on autism who are a little functionally high. They are verbal also, they are talking also a bit, but they have a lot of inflexibility. They do not like a change. They do not accept a change in their routine. They will not want to enter into a new space, talk to a new person, maybe a change of room. They will not like that. So that kind of, they have that tendency to be fixated कि ये चीज ऐसा होना चाहिए और इसी तरह से होना चाहिए. A change in the routine can disrupt and make them very anxious, and they can throw a big tantrum or a meltdown around it at times. So that is another milestone that we need to keep in mind. Sometimes they're very adamant, I want to wear this Spider-Man t-shirt, and they will not change it. And if you try to change it, they will again search and find, I want to wear that. And that kind of a repetition and obsessiveness can persist for many days. So then there could be highly restricted fixated interest of abnormal intensity. Like the child will have liking for wheels. Anywhere they'll see a bicycle or a car, or even a car standing in the parking, they will just go stand next to the car, just bend a little bit and just stare and glare at the wheel of the car. So that's the intensity, abnormal level of intensity and fixated interest. Either you will find a child walking it with their dinosaurs, and the mother will say, oh, dinosaurs are his favorite and he never leaves them around. And he always carries them. And if you take away that dinosaur, the child will start throwing a meltdown, because here the child, that's something that he has restriction and fixated interest. So the moment you take it away, the child will become extremely anxious and disturbed. Then comes some symptoms of hyper and hypoactivity to various sensory inputs. This is a very important part of the diagnostic criteria, because that is where you are going to face maximum challenge as pediatric dentists, because our clinics, our examination area, our procedure areas can be very sensorily overwhelming for children on autism. So there we need to first find out whether the child has any sensitivities, or is how is the sensory system working. You can ask a few questions around: is the child disturbed by very bright light? Is does he look at the lights like with small eyes and he tries to avoid it, or closes his eyes when he gets a bright light exposure? Does he close his ears when sudden drill sound appears? Or in home, when you switch on the grinder, mixer grinder, or a hair dryer, does the child get disturbed? So those are the kind of, they are sensorily oversensitive to certain sound and will avoid certain sounds. So and these sensory imbalances could be in each sensory system. It could be visual, olfactory, it could be tactile, touch wise. They would not like touch by anybody at times. And there could be auditory. So all the whole sensory system can have hyper sensitivity or hypo responsiveness, as in that child would not have adequate arousal to that sensory input. And sometimes you will feel that the child is too scared, too fearful, and sometimes you will find the same another autism child who is completely fearless. So there are different these symptoms in domain A, and then any two features in domain B, if justified, and the symptoms have been from early childhood, that is toddler years, less than 3 years of age, and that these symptoms are causing impairment in their everyday life, like impairment in socialization, impairment in communicating their needs, impairment in going to school and performing everyday tasks, then it justifies our DSM criteria. And one more criteria out of this, which is not mentioned here, is that these symptoms should not be primarily because of intellectual delay or intellectual disability. So we need to differentiate that, whether it is ID with few autistic symptoms, or it is primary diagnosis autism with intellectual, lower intellectual ability. So that part you can leave it on us. But a small cue that will help you understand is that a child with autism has disproportionate social communication delay as compared to their other developmental domains like cognition, physical development, self-help skills. They will be better, but the social communication milestones will be disproportionately behind. Whereas in intellectual delay, all the domains are equally delayed. It's a very easy way to differentiate which is the primary cause. So that's how you can differentiate. Then coming to ADHD. ADHD stands for Attention Deficit Hyperactivity Disorder, another very common neurodevelopmental disorder that we come across in our everyday practice. And why it happens, again, the neurobiological basis says there is some amount of dysregulation of the dopaminergic and noradrenergic pathways in the prefrontal cortex. So prefrontal cortex of our brain is the responsible for executive functioning of our brain. So there is reduced volume in this area, which has been seen in research on neuroimaging, on functional MRIs also. Again, there is a genetic etiology. It can be heredited from one of the parent as well. When you dig into the history, one of the parent reports, "Oh, doctor, I was also very active in my childhood. I was very hyperactive. My mother says he's just like you." And those soft cues sometimes they give. Of course, there are some genes they have identified, but again, there are diversity of those genes, and it's difficult to say which particular one is causing it. And as there's polygenic inheritance, multiple small defects in the genes are responsible. Again, the diagnosis is through DSM-5 criteria. So when we say DSM-5, there are 9 features in the inattention category. There are 9 symptoms in hyperactive impulsive category. And if 6 out of those 9 in either of the groups gets justified, then we call it as ADHD. It could be if it is only hyperactive impulsive symptoms, like the child is on the go, not able to sit, not able to focus at a task which requires sustained attention, always forgetful, over talkative, is not able to wait for his turn, always fiddling and fidgeting around. Teachers are reporting that the child is not sitting through the class and is always getting up from his seat, trying to disturb other children. He always keeps on talking in the class, and his work never gets completed. So those are symptoms. When it comes to inattention, then the child teacher will say he's sitting, but he's dazing out of the class. He does not know what is happening in the lecture. So all those kinds of symptoms will be observed and reported by the parents, and these symptoms are leading to again impairment. Whenever we think of symptoms, the symptoms are only symptoms of a neurodevelopmental disorder when they are causing some amount of delay or impairment in the child's functionality, be it occupational, social, communication, academic, any of these domains. If the child is having impairment in functionality, then these symptoms are considered in the diagnostic range. Then they really need to be dealt with. So ADHD can be predominantly inattentive, predominantly hyperactive impulsive type, or a combined type. All these 3 types have been mentioned in DSM criteria. Now coming to what are the medical comorbidities that we come across when we are considering autism spectrum. So there are plenty of medical comorbidities that we need to be aware about, because these can truly interfere in the how the child will present, what are the behaviors that the child can throw, and what are the sensitivities will increase if the child is not managed on these comorbidities. So sleep disturbances are very, very common. 40 to 80% of children around can have sleep disturbances. And if the child is not sleeping well, the child is bound to be irritable during the day, is bound to be restless. And if the child is not slept and has come to the OPD for a dental procedure, you can imagine how difficult it is going to get, because the child is going to be cranky, will not allow you to even touch or examine the child. So noting down quickly, if these are the concerns, then they need to be addressed before we plan a procedure or an intervention. Then epilepsy is common. So are there any anti-epileptics going? We need to also take that history, that has there been an episode. Sometimes they will just report a regular febrile convulsion, which the prophylaxis has been advised, but no epilepsy as such. But if the child is having some kind of an anti-epileptic, then you will have to manage your drugs and medications accordingly. And intellectual disability is also seen in approximately 30% of the children on autism. There, for them to understand, comprehend whatever we are trying to teach them or to explain them will be difficult. The intensity and severity of the challenge will be much more. So management is going to be even more difficult. Gut symptoms are very, very high, as in you will find a very common history of constipation in our children on autism spectrum because of various reasons. One, they have texture issues, they have feeding challenges, they will avoid eating fruits, they will avoid eating different textures in food. Then chewing is a problem. Mostly they are on prolonged bottle feedings, and gut dysbiosis is there. They are having vomiting, nausea episodes, reflux at times. And then because they are not toilet trained and it's difficult to toilet train them, they land up into GI challenges like constipation, vomiting, sometimes increase. Some children have leaky gut, so they'll be going to the washroom at least 3 to 4 times in a day. So these kinds of symptoms can be there. And obviously, when we plan some kind of an intervention at the dental end and we need to consider giving antibiotics, yes, we need to make sure that we give some probiotics, we give right kind of a psychoeducation to the family around the use of antibiotics if you've done some procedure which requires it. Because again, the moment they take antibiotics, their gut flora get washed out, and their behaviors, their symptomatology increases. So that is something that you must be aware, and then maybe psychoeducate the parent that it is okay, and it is going to be transient, right? So and you can definitely seek help, because they're educating them, preparing the parent and the family also is helpful, because then they don't get too anxious. Or what happens is they come to us, they say, doctor, for last 1 week the therapists are saying my child is regressing. What do I do? How can he regress? Now, when you dig into the history, okay, the child has had a viral episode, has had a ear infection, or has had something to do with and has received some kind of a intervention, maybe cough syrups or some antibiotics, which has flared the behavioral symptoms. So we need to be aware about that. Immune dysregulation is also there. You'll find a lot of children being allergic. Lactose intolerance can be there. They will have atopic dermatitis. A lot of atopy is seen in these children, so that we must be aware about. Yes, in the school going and in teenage adolescents, we must also be aware that they can have comorbidities like anxiety, depression, or OCDs, obsessive compulsive disorder, and they may be on certain medications for those. So there you have to again loop in with the psychiatrist as to what medications and how we need to do our procedures around that. Because many a times what happens is, when we even our pediatricians do that, many a times they start the URTI medication, the child is on risperidone for their behavioral concerns, and they will ask the parent, okay, just discontinue. And the child is on 1 milligram of risperidone, suddenly the risperidone is discontinued and the child has become even more disruptive. So their titrating or maybe coordinating with each other can really help. We can reduce the dose because he's going to be on cough syrups, which are sedatives, and that make the child more dull. So what we can do is we can reduce the dose, titrate the dose, or do some intervention which will not really make the situation over challenging for the parent. Um, those kind of things we need to be aware about. Similarly, when we talk of ADHD, there are various comorbidities. The child can have issues, learning disabilities, specific learning issues like dyslexia, dysgraphia, and dyscalculia. So, which is a very, very common learning challenge that children have as a comorbidity. There could be anxiety, mood disorders, again, maybe on medication. There could be oppositional defiant disorders, like whatever you tell the child to do, the child does not want to follow. He does not want to listen to you. आप बोलोगे ये करो, and the child will do exactly opposite of it. So 40% of the children with ADHD can have defiant behavior. They could be argumentative. They will have irritable behavior. So there you need to tackle them in a different way, because here the child is defiant and will not listen to whatever you're trying to say. Then sometimes they have tics disorder. You must have seen that movie of Rani Mukherjee where she has Tourette syndrome. So Tourette syndrome has both motor and verbal tics, and it's a common association in children on ADHD. So while giving various sedatives or analgesics to the children, or anesthesia, even sedation for the procedure, you need to be aware of these conditions, as some of those agents can trigger these conditions, and they can actually if talking about them, being aware about them can be very, very helpful for you, because you can be prepared then, okay, if something like this happens, how do we manage? Then coming to sensory processing. Yes, sensory processing challenges are very, very common in children. How these challenges can impact the dental care that we are about to deliver or plan to deliver. So their tactile sensitivities are a lot. There are aversion to oral examination, even rubber gloves, suction devices, the intraoral instruments that you would be using, gagging and withdrawal are common responses for the child, and it can scare or make them very nervous and anxious, because this is something that they don't understand, they don't know what is happening, and they don't like the touch also of anyone around them. They could be auditorily sensitive, the drill sound or the suction noise. All these could be challenging. Even an alarm in the in your clinic, which you are using, or a bell that you're using to call your support staff, can panic the child. Visual and olfactorily, yes, because we have a big surgical light on top of our chair, and the child could be oversensitive to a sudden bright light, or the strong chemical odors which are there. So all these could be sensitivities. If you take a history on the sensory processing for a child who with autism walking in, then you would know that okay, these sensitivities could simply impact the procedure or the treatment that I plan to do, and what measures I can take to reduce this. We'll talk about them also in the brief later on. So behavioral characteristics, again, behavior wise, how it can affect the dental care is children on autism, they have resistance to change. First dental visit requires extensive preparation on the parents' end also. So there they have restriction. They will not walk in. And the moment they walk into a new room, a new scenario, they start crying. And we sometimes try to pacify them in every way, but the child is not getting pacified because he will or she will take the desired time to get acclimatized to that new place. Then there is limited verbal communication, so obviously they can't express their discomfort to us. Self-stimulating behaviors, stimming will be there, which may get intensified because of stress in that new space. Then language wise, for many children who are functional, well functional, who can speak also, they do not understand our instructions very clearly. So there, when we are using the language, we have to be very clear that we use very clear, simple, short phrases to instruct the child, and there should be no phrase which has a double meaning or a sarcasm in it, because they do not understand that kind of a language. So use short, simple phrases to make them understand, or even their mother can be roped in to prompt whatever you are trying to explain, because sometimes they have a fixation that whatever my mom says or my dad says, I listen to that, but no other person I'm going to interact with. So there you can do that. Then there could be strong preference for predictability and structured environment. So when I say this, we have to use this for them to help you manage these children. So when you have a visit from a child, always tell the parents that we are going to take 3 steps before starting the procedure, where we want the child to first come to our clinic, feel the environment, look at the place, just roam around a couple of times before the actual day of the planned procedure, because then the child will come sit there for 10-15 minutes, will get used to the place, used to the people around them, and will also know if there is anything sensorily overwhelming that is disturbing the child. So we call it desensitization and priming the child to that environment. That can be considered before we plan something major, like a um, procedure or a detailed examination inside. And in that time, in those small 15 minutes visit that the parents will make a couple of times before an actual task, you can take a detailed history around the child's challenges, what he likes, what he doesn't like, the reinforcers. Like you can ask the parent if he likes a certain texture, like a slime toy or a car, that can be kept as a ready reckoner to calm the child down, because that calms them when you give them their favorite item. So those things can be used to calm the child and to be able to make your task easier. When we talk of ADHD, yes, the behaviors are mostly around, they will be fidgeting, running around in your clinic, will not sit in one place. While doing a procedure also, if you want them to sit for 30 minutes, seconds or 1 minute, the child will not be able to sit in one place, maybe if he's overactive. And you may have to give multiple instructions. You have to be very clear in children on ADHD. Direct language, stern explanation, because and early reinforcement. Okay, that's a well done, good job, you are able to do it, you're a fantastic guy, let's do it. Matlab, you will have to keep on reinforcing and motivating the child to be there. And if the child is on some kind of a medication like methylphenidate or atomoxetine, the stimulant or non-stimulant medication for ADHD, then you can ask them to take the medication in the morning when they come for the procedure, so that the child is having their full attention and is able to hold the attention and is calm or is comprehending what we are telling them. And many a times, if some procedures require the child to come empty stomach, there maybe with a sip of water, they can take the medication, and thereafter 4 to 6 hours can be kept empty stomach and then start the procedure. So those kinds of small measures you can take. Yes, when we talk of oral health profile, and neurodevelopmental conditions like autism and ADHD, there are higher dental anxieties, 5 times higher dental anxieties as compared to neurotypical peers. Patients with or children with ASD are more likely to exhibit dental fear related avoidance because of the sensory sensitivities. As I told you, they are overly sensitive. Then there is 40% increased risk of caries because of various reasons, diet preferences, toothbrushing. They are sensorily not allowing their mother to clean their teeth or put anything in their mouth. Or there will be poor oral hygiene. There could be some medications which are leading to dental caries, etc. So I'm sure those you are all much more aware than me. But yes, there are chances of them having oral challenges are much more. 30% chance. Bruxism I see in every third child that comes to my clinic with autism. So bruxism could have various medical causes. We do that. We give iron supplementation. We deworm the child, but many a times it starts affecting their dentition, especially in sleep when they are having, it could be heightened arousal states for the child. So there at times uh, we both need to be in sync with each other and be able to, I should be able to refer the child back to you on time. And uh, it has to be again a multidisciplinary approach. There could be traumas because children with ADHD and ASD are hyperactive. They are on the go and they do not have that sometimes that instant coordination abilities, leading to a lot of trauma and avulsion. So these are some of the common challenges that we come across. Yes, pharmacological considerations we need to keep in mind are that children with ADHD can be on stimulants and non-stimulants, and they can in itself increase some dental risk, also elevate the heart rate, they reduce appetite, and hence uh, drugs like epinephrine, which can again increase heart rate, should be given in a careful way. Antipsychotics, mood stabilizers are given in children on autism, where they have a tendency to gain weight, and some, if given in accidentally in higher doses, they can lead to other challenges as well. For Valproate, if somebody is on a long duration of Valproate, doing a LFT or a liver enzymes and coagulation profile before doing a procedure can be very important. Again, sedatives, benzodiazepines, if the child is on some kind of a sedative medication, like child has seizures, many a time the child is given some benzodiazepine in combination with the anticonvulsants that they take. So there again, we have to take that medical history so that we can plan how much we are going to give during the procedure, that it may act as an antagonist or enhance the current outcome. So taking that detailed history can be very helpful. Again, anticonvulsant like phenytoin are known to cause gingival hyperplasia, and the duration, and we need to monitor for that on regular basis and take dental opinions also. Behavior management is simple, that we can keep few things in mind. Desensitization can be very helpful for the child. And desensitization, as in if you think that the child is not going to open, the sound of the vibration or the touch of the machine, you can start doing small sessions, brief session. Okay, we just touch this, we just experience this for a short duration. Gradual, slowly increasing, progressive exposure to the child can desensitize them, and their anxiety around experiencing that will start reducing. So that's what I said. giving them 2 to 3 prior visits where you take only history, you do general examination, do some prophylactic stuff, and expose them to the environment a couple of times so that the child becomes used to it. Just playing the instrument, like आपका जो drill machine है उसको just switching it on and off briefly but not inserting in the mouth is something you can do just to desensitize. It's okay, see, nothing is happening. And if their parent is also undergoing some dental procedure, then it can be seen, see, I'm doing it on mama is fine, you are going to be fine. So that's going away a step ahead, but yeah, desensitizing them by small exposures can be helpful. When again we talk of sensory methods, yes, if a child is oversensitive to a sound, then you can ask the parents to get sound blocking headphones so that the child does not tend to hear those drill sounds or suction sounds or switches, sound switching on and off that will disturb the child extremely. So those small measures can be very, very helpful and will enhance or make your task easier. Communication again will be depending on how much is the level of the child. Is the child verbal, non-verbal? Is the child able to communicate? If the child is non-verbal, then and you want the child to brush their teeth twice, you should have a visual chart which shows visually the sequence or the steps to doing a brushing activity, or what you are going to do. Even that can be put up in the form of a picture method, so they learn visually, they understand through a video. Maybe if you show them a video, then also they'll understand, okay, it is going to be like this, and then in the end you can show a smiley face, see the person is happy because there's no pain now. So that kind of a communication can help the child to become again more oriented to what are they going to expect. So that helps them to be calmer. Many a times they need emotional prep to be able to experience what is coming next. Sudden exposure to an experience can throw them into they will go in a meltdown because they get into that state of anxiety and shutdown then. So communication has to be clear. If the child understands language, then use short, simple phrases, maybe one-liners to explain them what is going to happen. Parents, you can loop in the parent to help you do that, because many a times they are much more responsive and confident of the parent telling them about the same thing. Even you can ask the parents to prepare them emotionally from home a couple of days beforehand so that the child is ready to experience what they're going to. And finally, reinforcement works very well. Small reinforcement here and there can really pep them up and keep them motivated to continue with whatever treatment you are trying to uh, do. And actually, what the doctor can do is maybe just make the child a little comfortable with you beforehand, before going in for something major, some procedure or maybe intervention that you plan to do. Make the child comfortable. You can have a few squeezy toys, a few texture toys, a few books in your many of the clinics in Gurgaon I have seen have wonderful roofs. So the moment the child sits on the chair, they get to see those colorful roofs on top, and they are really distracted and happy, and that helps them. That's like a reinforcer for them. So those kinds of small, maybe hanging a toy on top where the child is looking at it and is enjoying. They like revolving things. You can put in something colorful on top of their head while they are seated so that they get distracted. Maybe light, soft music, a rhyme of their choice can be played so that the child feels calmer, because there you are giving them an environment which they usually experience at home. So all these small steps can really be helpful when you are planning a dental check and care. Yes, sedation and anesthesias may again, you need to make your specific consideration as to what is tolerated, what method to use. I think you are the best judge for this. I have very little knowledge, but these are again oral sedations if you are using or IV sedations or inhalational sedations. You need to be aware about any cross reaction with any of the medication, and drug history, medical history is very important here. Environmental modifications can be done, like waiting area can be quiet. If the child is overwhelmed by the situation, reduced fluorescent lighting when you are planning a procedure for a child with autism. Even the operatory rooms can have dim lights, sunglasses for patients. If the child is oversensitive to bright lights, you can use sunglasses. As I said, weighted blankets can be used to give them pressure. Noise cancellation through headphones can be used. Fidget toys can be used. First appointment of the day can be kept so that your clinic is not busy place, and it could be short duration and assisted by the staff. Again, use visual cue cards to communicate. A social story by the parent to prepare the child can be very helpful. Establish a clear stop signal. And you can also use a pain scale, smiley pain scale, if the child understand. Ask them to just point if the child is nonverbal, to be able to tell if they have any discomfort. And minimizing verbal instruction to one step at a time. These can be very, very helpful. Then, the role of the team is very important here. Each and every person needs to be aligned and be aware of how to deal with a child or a parent, and not make them feel out of the box and uncomfortable. And even your team members can be primed a little bit on how they can manage. Of course, it's a multidisciplinary management where there is a there is a pediatrician, there's a psychologist, and there's an occupational therapist. Parent caregiver, of course, is a very important stakeholder here, and special educator, speech language. All these people play a lot of role, and they all need to work in coordination with you when you are planning something for the child. And if need be, an interdisciplinary and interactive communication with these professionals can be helpful. If you've done some tooth extraction, the place is raw, painful, and this child goes to a speech therapist who's doing a deep oral motor massage. The child is screaming because uska to abhi procedure hua hai, right? So writing right instructions for the speech therapist again can be helpful. These kinds of small things we can, if we do, we can make a lot of change to the quality of care that we will ultimately deliver. Early diagnosis and early intervention, be it a neurodevelopmental disorder, be it a dental challenge, concern, everything, for everything, early identification, I'm sure you know the importance, can make a lot of difference. So whether it be a child coming to you for the first time where you feel that this child has challenges, you do your dental bit check and then you need to refer them, or it is coming to me and I find out, okay, the child maybe peep a quick look into his oral cavity and send it to you. It is always important that we do early diagnosis and early intervention. Okay, few take home will be: know your patient well, modify your environment, collaborate actively with other teammates, prevent first, treat later. So when I say this, we need to work at preventing certain things. I'm the technical aspects of pediatric dentist. You people are way ahead and you know everything about it. I am not the expert there, but yes, prevention is very, very important. Building trust over the time is important with the parent, and these guidelines were taken from some of the standard practice guidelines, American Academy of Pediatrics, DSM-5 and CDC, so that we talk scientific evidence-based stuff. I think that is all from my side. And if you have any questions or any query or any specific case-related challenge that you come across for children with neurodevelopmental disorder, I'll be happy to answer them. Okay, we have some questions in the chat box. I'm not sure.
Yes, ma'am. We have certain few questions. Ma'am, the first question is like, how do we inform the parents and convince them to go for autistic evaluation in case if they have not been identified, and the dentist in the clinic, if they see certain signs and symptoms of autism, how to convince the parents to go for further evaluation? That's the first question.
So, yeah. So, speaking of the diagnosis, can really put the parent a little at the back seat, and the dentist may not be comfortable also doing that. So, we do not recommend you telling the patient your child has autism spectrum. You can always say your child is lacking some developmental milestones, and we need to look at if this is significant, and we need to. I would recommend a detailed evaluation for the child, because that will really help your child with the development. So recommend a detailed development evaluation for the child. If you see some red flags, then parents do tend to poke in, doctor, kya lag raha hai, kya lag raha hai, what do you think there is? So you can say there are some red flags, there are some delay in communication, there are delay in his quality of interaction, and it will be important that you get a detailed evaluation, because sometimes using those terminologies can really confuse the parent. और अभी डॉक्टर भी श्योर नहीं होता है कि ऑटिज्म है कि नहीं है, बट बोल तो नहीं रहा है, स्पीच डिले है कि ऑटिज्म है कि क्या है, वी डोंट नो. So just telling them milestones appear to be delayed, and a thorough evaluation is recommended.
One more question related to the same this thing. One of the participant is asking, is there any case history form available that they can use it to know that the child is having a sensory issues?
Yeah, there are sensory profiles which are available online also. There are sensory profile. If you put in the word sensory profile, you will get a questionnaire. So there is a
Okay.
short sensory profile and a long one. So long one has, I think, around 140 questions, but a short one has 65 questions. So that can, for a child with neurodevelopmental concerns walking in the clinic, they can simply give that short questionnaire to the parent, and they can quickly fill in, and you can just have a look at it. You don't need to score it. Even by looking at it, you will come to know that these are something that is worrisome for the child. And it is system-wise questions. So all the sensory system has different set of questions.
Ma'am, is it age specific, like for a 2-year-old as well as a 6-year-old?
Yeah.
Is the questionnaire, or there is any variation in that?
No, there is age specific, 0 to 3 and then above 3.
Okay.
And you can also go to the site by pathways.org. There also you will find these questionnaires. If you go there, then you'll get age-wise questionnaires. Every 3 months gap, age-wise you'll get the questionnaire, sensory. So you can take that. But those are very detailed. I don't think you will have that much time. But if you want to do some research or something, then those can be very helpful.
Okay. And the next question is, so do we have time to take some more questions? Anand sir?
Yes, ma'am, we can.
Yes. So the next question is like, does ADHD come under the category of neurodevelopmental disorder?
Yes, ma'am. ADHD is a neurodevelopmental disorder. Autism, ADHD, learning difficulties. Social communication delay, communication disorders. Per se, I would say intellectual disability does not come in the NDDs. It is a separate classification in DSM. But autism, ADHD, learning difficulty, social communication disorder, and social communication delay, developmental coordination disorder, these all come in NDDs.
And the next question is there a strong gut-brain axis link related to the NDD, that is neurological development?
Yeah, there is a lot of research, and even my PhD thesis was on gut-brain axis. So my randomized trial, I used probiotics as a intervention to examine what is the outcome difference. And my paper is also published in BMJ Pediatrics. You can go through it. But yes, there is a gut-brain axis, because children on autism spectrum, about 40% have been, it is seen that they have some GI symptoms or the other, and which is much more than neurotypical children. And as I spoke in my presentation also, there are multiple causes for that. And the gut, see, from 0 day, when the child is born, it is like a sterile environment. And the moment the child is being delivered, whether the child is born vaginally, some microbiota goes in through the vaginal fluid. And then if the child is born cesarean, then it is more sterile, nothing is going in, or the nature of bacteria that will go in will be different. Then if the child is breastfed or given a top feed, again the nature of gut flora is going to be different. If the child is breastfeed, breastfed, then the flora is different. If the child is not breastfed, it is different. Or is fed through a bottle feed or formula feed, then as they're growing up, they start their complementary feeding and other stuff. What they're eating, what they're not eating, how many times antibiotic course was received during their first 3 years. So the gut bacteria, gut flora matures at 3 years of age, and the same 0 to 3 years is the time where the brain is also peaking developmentally. So
Okay.
it's growing in the same age group. So
Okay.
hence, managing this is very important. Anything we are doing out of the box, out of physiology with the gut is going to affect the neurodevelopment. And it is connected through neurological pathway, enteric system is there, then there is hormonal pathway. So there are various pathways through which the gut and the brain is connected, immunological pathway. So they are connected. Even when, let us suppose we have to go for a viva and an exam, our gut starts moving fast. Our brain sends signals of anxiety and our gut moves fast. So we have so many evidences, and we have a lot of scientific evidences also. There is a strong connection between gut brain.
One of the participant is asking, can we give probiotics when we prescribe antibiotics to the children? Will it help?
Yes, it can be helpful because it will help to restore the gut health. And especially for after a course of antibiotics, maybe few days of probiotics can be helpful. Or you can also give them dietary advice, like having curd. If the child is not on anything which is restrictive in diet, is not following any restrictive diet, then you can definitely ask them and give probiotics.
Is it mandatory? Like, this is my question.
No,
Like, whenever
it's not mandatory anywhere. No guideline says as such that you need to give it.
Okay, but it will be helpful if we give.
But it can be helpful. You
Yes,
can
ma'am.
ask the parent to give them a bowl of curd also.
Okay.
Homemade curd, because homemade curd has lactobacilli. It will help to restore.
And one last question.
Diet rich in fiber. Fiber is a prebiotic. It acts like a prebiotic. So a diet which is rich in fiber can help regrow the gut bacteria naturally also. So if you stick to that process, then also. But psychoeducating the parent about these things can be helpful.
We'll take one last question.
Yeah.
One of the participants is asking, beyond genetics, how significant how significant are environmental and psychosocial factors in rising the prevalence of ADHD? And are they under recognized?
Yes, absolutely. The environmental factors are something that we can control, and genetics we can't really make too much of change. But knowing environmental factors, psychosocial factors, we can modify them and actually prevent the child from going into ADHD. A child who has a genetic phenotype but has received very encouraging or very conducive environment may not even present with the symptoms. So that is how the environment impacts. So there rising screen times, rising game time, mobile times, they are impairing and causing a lot of screen addictions in children. And many a times children with screen addiction presents like ADHD. And you have to figure out whether it's actually ADHD or a screen addiction. Symptoms are same, nearly same. The profile of symptoms is the same. So yes, environmental
something called
factors.
as digital autism also. Recently, I had heard about
No, ma'am, that's not a scientific term, I would say. Virtual autism or digital autism. Nowhere that term has been classified but because of the high exposure of screen, the child is not getting the social environment that they are expected to experience and learn through. So it's leading to deprivation and neglect from the social environment, which is leading to problem with the behaviors. So it is one of the environmental factors, but causality is not established. No research right now is establishing the causality. They're only finding association.
Participant is requesting for the website regarding the information you told me, pathway.org. Can you put it in the chat, ma'am?
Yes. Pathways.org, and even you can also visit our website. We have a lot of study stuff on the continuourkids.com. We have some questionnaires, disability questionnaires and forms also uploaded. So they can go to both the sites and have a look. Read about autism and different neurodevelopmental disorders. Our site also has a lot of information.
Ma'am, one more question has been raised actually.
One more question. Ma'am, one last question. Can you please take this one?
Yes.
Ma'am, one participant is asking, does deworming help with bruxism in an otherwise normal or healthy child?
So bruxism, one of the cause is anemia. And why anemia happens is for a child who's generally they put in everything in the mouth because they have a mouthing tendency. So, and deworming is generally done for a neurotypical child also at 6 months interval. So, we need to treat anemia. Look, take history of pica, treat anemia, and also when you are treating anemia, you need to deworm the child so that if there is worm infestation leading to anemia, then that is also taken care of. So when you treat all that, you are managing the medical side, and then you'll see if the bruxism is reducing or not. At the same time, you need to keep looking for, is it behavioral? Many a times it starts with a deficiency and it becomes a behavior. So you have to then manage the behavior also. You need to, many a times my children, by just treating anemia, we see that the teeth grinding has reduced tremendously. So that's the medical cause, but the behavior aspect of it has to be taken care, and the outcome that it is causing to the dental structure, that has to be again dealt with. So it has to be dealt in these three phases, I would say.
I think that's all, ma'am.
Yeah.
Thank you, Sam. Thank you.
Thank you. Thank you so much for the opportunity.
Yeah, certificate, please. Ma'am, kindly accept the certificate, ma'am.
Thank you.
Yeah.
Thank you so
good
much.
evening.
Yeah.
Thank you, Himani, ma'am.
Thank you.
Thank you, moderators. Madhu sir, kindly
Thank you,
accept
Anand.
your certificate.
Thank you.
Thank you so much for your time. And thank you, Indira, ma'am.
Thank you, sir. Thank you so much.
So we'll go to the next session. The session is on dental aspect of intellectual and developmental disabilities, autism spectrum disorder, and ADHD. And it is by Dr. Mausumi Goswami. And the moderators of the day are, of this particular session is Faisal CP sir and Dr. Ramesh Krishnan sir. Dr. Faisal CP is Dean Academics at Kannur Dental College, Kerala, and the Clinical Director of Special Olympics, Kerala State. Completed his graduation and post-graduation from Rajamuthaya Dental College, Annamalai University, Tamil Nadu. Former Vice President of ISPPD in 2024-25 time and Chief Editor of ISPPD Smile Times. He served as a State CD Chairman, IDA Kerala State in 2019-2021, National Executive Member of ISPPD for 6 terms, Fellow ISPPD Award in 2022, and has a publication of 120 plus in national and international journal. We welcome you, sir.
Thank you. Thank you, Dr. Antaraj.
Dr. Ramesh Krishnan is a distinguished pediatric dentist with 30 years of clinical experience and over 22 years of academic teaching. Completed BDS from Vinayaga Mission Dental College, Salem, and MDS from Bapuji Dental College, Davangere, and holds FD Associates from Edinburgh and FRCS from England. Served as a faculty for 13 years and a registrar in pediatric dentistry at Armed Forces Hospital, Saudi Arabia, 2018 to 2024. active in IDA, ISPPD, serving as an ISPPD treasurer, joint secretary, executive council member, and fellow ISPPD in 2022. Over 60 plus index publication contributed to the textbook and present widely in national and international conference. Thank you, sir, for being with us.
Yeah, thank you so much for your kind introduction.
Yeah. Kindly introduce the speaker, sir.
Very good morning to all of you. I would like to introduce a towering personality in pediatric dentistry. It doesn't need a formal introduction, but as the situation demands and as a protocol, I would like to introduce Dr. Mousami Goswami. She has graduated and postgraduated from King George Medical College, Lucknow. She has over 30 years of academic experience and now serves as a professor, head, dean research, and institutional ethics committee member secretary, and is affiliated to ITS Dental College, Greater Noida. She has authored more than 100 publications and has contributed to 5 chapters to 5 textbooks in international and national peer-reviewed journals. She has delivered lectures globally and served as guest faculty at Sri Seva Sagur Ramgulam Medical College, Mauritius, enhancing medical collaborations internationally. She has received the ISPPD Fellow Award and Award of Excellence from KGMC Lucknow in the year 2017 for her outstanding contributions to dentistry. She is the former president of ISPPD in the year 21-22, and she initiated the certificate course on special healthcare needs in dentistry and is successfully completing multiple batches. Recently, she has been nominated to the National Dental Council. I congratulate her and I welcome her to this program. Over to you, madam.
A very good morning to the moderators and the participants. I welcome you to my presentation on dental aspects of autism spectrum disorder and attention deficit hyperactive disorder. Wherever we have to deliver treatment to the children with special healthcare needs or any other child, there are 2 aspects to it. Firstly, that we have to manage whatever problem he's come with. And secondly is that we have to deliver and manage his behavior so as to instill a positive attitude towards the dentistry, pediatric dentistry. So there are 2 aspects to it, and we have to fulfill all of them whenever we are treating the child, patient with or without special healthcare needs. So to treat them better, we need to understand the condition. So now my previous speaker has already spoken about the medical aspects of ASD and ADHD. I'll be touching a little bit about these 2 things so as to build the topic. So autism spectrum disorder is a complex developmental disability. It's a neurological disorder that is seen in very early years of life, the first 3 years of life, and it impacts the social interaction and communication skills. Earlier, there were 5 identities, separate identities, and now they have been clubbed together to call it as a spectrum. If you look at the prevalence, then it is more in the boys. 3:1 is the ratio between boys and girls. And the prevalence in India is very high, 1 in 65 or 1 in 68. And they have said that a small proportion of them is also linked to Fragile X syndrome, tuberous sclerosis, Rett syndrome, and Angelman syndrome. But we have to understand why they are prone to dental diseases. The first is food sensitivities. Now, you would have heard that these children, they are sometimes, refrained from taking gluten and casein because they say there is a leaky gut in these children. So, because they have the junctions in the mucosa are not that tight, so these molecules, they come out of it and they pass the blood-brain barrier, and they somehow impact the brain and they cause the anxiety. So food is also linked to the anxiety. But many studies have also disapproved them. But they definitely have food sensitivities in the sense the selection or the texture of the food is very important for them. Any textured thing is not at all tolerable to them because they have issues of sensory processing. So they're not able to process them properly. So the parent, as a mother or the caregiver, they will try to puree the food. Any vegetable, any fruit with any kind of texture, they will not like. So they will puree the food and they'll give them more processed food. So we know that how they are linked to dental caries. Also, these children have a tendency to pouch the food a lot. So when they keep the food in the mouth for a long period of time, when the food is full of carbohydrates and processed food and pureed food, wherein the musculature is also not working much. So the self cleansing activity is also not much. So the dental caries would be mainly high. If you look at the medications with the children with ASD or ADHD are given for hyperactivity, repetitive behaviors, and aggressive behaviors, we see this as a side effect. The main common side effect in all these is xerostomia. And we know how xerostomia predisposes a child to dental caries or periodontal problems. Together with it, they also have poor muscle tone, poor coordination. Okay, there's a lot of drooling of saliva. Parents come to us, they say that they are not able to expectorate also and they are not able to swallow also. So all the time they are drooling. How to make them brush their teeth? It's difficult. So it's because of the poor muscle coordination, even the oral cavity. And you see they also have strabismus. Hyperactive knee would be there in them. And eventually 30% of these children would develop epilepsy. So we have seen that dental caries is on the rise. Okay, they have problems in brushing the teeth because maybe the drooling is one part. Second is the texture of the toothpaste. They might not like the toothpaste at all. So we have to, the bristles of the brush, they might not like. So slowly, we have to make them adapted. There are lots of videos which talk about how to brush the teeth. It has to be done. The instructions have to be given very, very slowly and in a systematic manner so that these children learn. And the periodontal diseases are also high. And because of the poor muscle tone, what we see is maxillary crowding, posterior crossbite, and increased overjet. Second is the communication problems. Most of these children are non-verbal. So when they have a toothache, they might refuse to eat. And the parents might not even come to know if he's having a toothache. He might even not be able to point it out, open the mouth and point out that I have a problem over here. So the parents come, they say the child is hitting himself or he's just not eating. So all these problems the caregiver needs to analyze and he or she has to come to a conclusion that maybe a tooth is a problem and then he can come to a dentist. Then the behavior, we've spoken about it, that these children have a lot of anxiety. Anxiety because again, there is differences in the cognitive and the sensory processing. So when we talk about it like this, I will just give you an example. Suppose as I'm talking to you, there are so many sounds in the room, maybe where you're sitting, the fan is there, the AC might be working, there may be somebody talking outside, there may be the vehicles there, the birds may be chirping. If you're there in a dental setup, maybe there is the noise of the aerator, the suction, but we are able to filter everything. We are able to concentrate on whatever we want to. This doesn't happen in these children. Their processing is, they are not able to filter out. They are not able to focus on one thing. So as a result, everything comes as a huge overload to them in their minds. So then you will see them, flopping their hands or unusual behavior, running around, and they are totally anxious, very, very anxious. They become a lot of worried to the extent that go into panic and they cling on to the caregiver. So they have a strong fear of separation. So whenever we are treating them, we have to have the caregiver around. That is one thing. There are two terms, under responsiveness and over responsiveness, and we always know that these children will have some form of sensory processing difficulties, and they exhibit high neurological response and over responsiveness, to the extent that whenever the situation is there, the result is fight, flight, or fright. There could be detrimental oral habits in them. It is the self-injurious habit also, lip biting, tongue thrusting. They might be poking the gingiva, and because of the seizures, they may have dental trauma. They also have hyper gag reflex. This is also seen in them. Typically, you will see self-injurious behavior. That means they will hit themselves, they will scratch, they will pull their hair, they will rub themselves, cut, hit, even take some object and poke here and there, even in the eyes. And most of the time you will see that they will have a scab or something on the forearm, because I have seen that children will just take the hand and bite themselves whenever they are in a situation which they are not liking. Also, when they are clinging onto the parent or the caregiver, the parent will have a lot of marks on the forearm, on the arms. We have seen it very commonly. So, if I summarize all these things in the dental operatory, what will be the difficulties? First is the communication. Second is the repetitive behavior. Whatever you may say, the child may give you back. Social impediments, sensitivity issues, and motor difficulties. Coming to ADHD, ADHD is again a neurodevelopmental disorder, and there is inattention, hyperactivity, impulsivity, emotional dysregulation, and developmentally they are all inappropriate. The prevalence is again 7 to 8% in the children as well as in the adolescents, more common in boys. Now, ADHD and autism, they coexist. That's again another difficult thing. They say that 50 to 70% of individuals with ADHD also present with comorbid ADHD. So, when we talk of ADHD, we talk a lot about executive dysfunction. So, just to explain a little bit about it, that means the decision-making process is hampered in these children. Now, giving a small example, suppose I am driving back home from my workplace, I might take an expressway to go home, and one day I find it that there is a congestion and there is a blockade. So I have to take an alternate route. I'll just open up my Google and I will see the GPS where the alternate route is there, and I will follow. But anybody with ADHD will have a problem. They will not be able to take any decisions. This is the simplest of thing. Maybe if I take it in a child, then a child, maybe you have given him something to eat. Every day you put a spoon over there and you send it to school. One day the spoon you've forgotten to put. The child will not look for the spoon anywhere else in the bag. He will not even ask his friend for a spoon. He will just keep sitting. He will not know how to eat. He might come back home without having had his food. So this kind of, just to look for any alternative method or any decision making is difficult with these children. I'll just show this video to you all to make you understand. This child has got autism as well as ADHD. So he is having these coping mechanisms. He's flopping his hands, clapping his hands. The parent is there with him. He's able to walk, but you see, he's very fidgety. He won't sit in one place. Now, when we talk about the diagnosis of ADHD, it is very clear that the symptoms need to be present in at least two kind of settings. At home, maybe at school, maybe at workplace, maybe in the playground, maybe in the temple, maybe in the church, wherever, but at least in two different settings, the child must be exhibiting the same kind of behavior. And that should negatively impact his academic, social, or occupational functioning. In patients who are less than 17 years, 6 symptoms are necessary. Those more than 17 years, at least 5 symptoms are necessary, and this is according to DSM-5. And we have 3 types of ADHD: inattentive type, hyperactive type, and the combined type. When we look at the inattentive type, here the child completely lacks the ability to concentrate. So he has an attention deficit, and he will not do his homework. So whenever we take the child to the dental operatory, the challenge is that apart from the fear of the unknown, he might, lack the interest to listen to us. Whenever we talk to him, his mind might be wandering. He must be daydreaming. He just doesn't pay attention. If we are teaching him how to brush the tooth, he might not even listen to any of the dental instructions. So we have to repeatedly tell him that we want this out of you. You have to again and again build his concentration and align him with what you want to do. And maybe if he is not agreeing, he will refuse the treatment also. So another thing is hyperactivity. That means the child is very, very all the time on the move. He's not ready to sit in any place, and he's very restless. And and sometimes he's so talkative, he might just interrupt conversations. So when you're trying to treat these children, he's very fidgety. He might not like to sit. He's all the time moving. And even if you have to take an X-ray, you want the child to be still at least. So when you're doing the procedure, so and then there may be verbal outbursts may be there, and it is difficult to control or make him still. That is the major challenge. So this is Ahmad, and he is a child in ADHD. You see, all other will be sitting, but he will be running. So if you look at what can be the repercussions of these in the dental perspective, the child may be more prone to dental caries because he will definitely not spend time to brush his teeth properly, making him more prone to dental caries or periodontal problems. And because he is so hyperactive, maybe he's falling all the time and he's suffering trauma. And these kind of children always have fear issues, and they may resort to some kind of, again, deleterious habits of nail biting or bruxism, things like that. Now, it's advisable to treat the child whenever he is the best in his moods, and mostly it's the morning time because he is more alert, more attentive, and we can render the treatment the best. In ADHD, again, we said that restlessness decreases the focus of attention and impulsivity. And we have also seen that later on. So strategies for care. So when and how should we intervene? Let us talk about that, because whenever the child comes to us and we start with the tell show do technique and we go further and we know that we are failing, so our patience also goes down and we try to then take the child under general anesthesia. Now here we have to learn how to deal and how to manage the child non-pharmacologically. Only when we fail, then we will take him to general anesthesia, because that should be the last resort. So what are the factors that we should consider before implementing management strategies? The first is the dental condition. Now, the children will be brought to us only when they have any pain. The parent has so many other things to take care about, especially for these special children, that the dental part is a big neglect. All of us will understand this. So when he has come to us, that means the child has pains up there. And there are very few parents who will get for a routine treatment. So again, it is a challenging thing because the condition is now bad with the child. Then the age. If he's one child, it is easier for us to restrain him, and we can give better treatment, because the passive stabilization is easier with children who are smaller in age. When they grow up, they are more bulky, heavy, because and they are larger in their volume also. So it's difficult to restrain them. Then level of intellectual disability. The higher the disability of intellect, the more difficult it is to bring home what we want to tell the child or what we want to expect out of the child. Then cooperation, communication, the caregiver's desires, and how much the child is dependent on the caregiver. All these things are factors which we need to look into. Now, there are 4 steps to intervene these children. There's a preparatory stage, introductory, desensitizing, and treatment. But no 2 children are the same. Similarly, when they come to us, every treatment has to be customized, looking at their convenience, their parents' convenience, and our convenience. Only then we can gain the cooperation of the child. Now, the Wright's triangle will be completely inverted, meaning thereby that you will be able to deliver it to the child only with the help of the parent. That is very, very important. So, role of parents is immense. Pre-visit conversation. Now he's come to you for the first time, but you will consider that as the first visit and it's a pre-visit. So we will discuss all the challenges with the parents. Now we said that these children have a lot of stomach issues because of the food they are taking, food sensitivities. They're having a lot of stomach issues means they have constipation, stomach aches, that disturbs their sleep, that changes their mood. Okay. And maybe they have atypical sensory responses. Then we have to talk to the parents and understand about the child's specific needs and preferences. And so we are able to develop the best strategy that is possible. So special child has a special parent, and studies have shown that the parents are predictors of the behavior of their child. So we have to explain the procedure to the parents, the methodology, the alternatives. We have to tell him that the child might require 2 to 3 dental visits just to patiently sit in the chair. And the intervention can only be planned by educating the parent about the sequelae of the dental diseases, that if he doesn't get them done, what all the child can land up with. And passive stabilization, so as to render all the treatment in the safe and better manner. So let us see how we adapt the oral care protocol to support the sensory issues. So I have to ask the parent if he has any visual issue, means he covers the eyes. Is he able to brush the teeth in the washroom with all the lights around? If not, if he is not able to brush the teeth in the washroom, if he is coming out and he's brushing it elsewhere, we come to know that bright lights, and as it is, bright lights do cause problems with them. So flickering and bright lights should not be there anywhere. The room optimization, that's the term which is used, means you have to declutter. Usually we love to, flaunt all the flyers everywhere in our operatory. As a pediatric dentist, we like to use loud colors, yellow, red, so we have to have neutral colors, cool colors. The light should not be fluorescent. It should be soft, warm, natural, and it has to be removed of all the unnecessary flyers. What I wish to say is that they want a very neutral kind of a place. There should be not much distractions. Then something, which has really helped me is the placement of an aquarium. All these children will stand next to the aquarium and look at the fish, how they move. That means anything that is projecting a slow moving object calms down anyone. So these bubble tubes are there, which again helps in calming them. And these days we see even in the airports, etc., we have seen that bubble tubes are placed. Then the noise. This is very important because we have such a lot of noises in the dental operatory, the suction, the erotor, and they should have the noise cancelling headphones. Then tactile. When the child is there for the first visit, please make him introduce the gloves and the cotton rolls, because this is what you're going to use. If you're using the rubber dam, introduce him to the rubber dam sheet also, so that he knows that these are the things which we are going to put in the oral cavity and he should be familiar with it. If we have to give a mask, then the mask also should be introduced in the very first sitting. So for the tactile, sometimes this is a hugging chair, something which, makes them, goes around them, that makes them feel comfortable. So weighted blankets or weighted stuffed animals, these are something which help them. And the fidgety toys are there. They also feel very nice when they have these fidgety toys, they feel comfortable. Then the gustatory and the olfactory issues, again, this is very, very important because we have so much of smell in the operatory, maybe of eugenol, of any other dental material. So we have to ask the parent if he is a picky eater and what are the smells of the foods which he tries to avoid. So we can manage it better. Now there's something called vestibular movement. That means whenever the feet leave the ground, we start losing our confidence. So meaning that whenever we have to lift the chair up or down, we have to, we should not do it when the child is in the chair. Rather, we make the child get out of the chair and then recline the chair and again make him sit, or we have to do it very, very slowly. So the first appointment should be a desensitization appointment, and we should fix it when the operatory is less busy, when you do not have children who are crying, and he should have a short waiting time so that there are no meltdowns. All we want is that he should be familiarized with the environment. So this is little Anika who has come to us on the first visit. It's a friendly visit. We have given her some books and we have given a flip book to her where we show, and we also have a PPT where we show what all we are going to do. And we have given videos for toothbrushing. We slightly massage the cheek with the gloves, with the cotton rolls, so that she knows what you are going to do. And because we are going to give her nitrous, so we are introducing the mask to her. We should also teach the child how the etiquettes of sitting in a dental chair. Means once he is sitting, he should put his hands by the side or on his stomach. He should put the feet straight out. He should open the mouth and hold it open for some time. Then we should clean it with the, when we put the erotor, we can say we have cleaning with a power brush. We should see how we are taking an X-ray, teach him how to spit in the sink. All these things should be done in the desensitization appointment. Some people like to give them the welcome packets. That is the picture of all the people in the dental operatory, you know. So we do the examination very slowly, make the appointment short and positive, keep the dental instruments out of the sight, and keep any comfort item, whatever the child might like. Immobilization techniques are to be used only by the parental consent. If all the other strategies fail, the pharmacological options are useful, sedation as well as general anesthesia. Now, routine and continuity, we all know that these children love routines. They love to be regular with a regular pattern. Means that the same doctor, the same auxiliary staff, the same room, the same kind of, if you are projecting any TV or something, the same kind of cartoon. So the same kind of language. So that is how they are very strict on their routines. Now, there are a few steps in how to improve the management. They could be due to visual pedagogy, the SADE, a sensory adapted environment, dental environment, the applied behavior analysis, and behavior guidance methods. Now, visual pedagogy is something very good, and this can be very helpful. So, children with autism, they respond better to pictures rather than words. So, we can have books with colored photographs, and there could be video modeling, social stories. Now, these are the various, pictures you see, and this is one of our very favorite videos. We like to give it to the children. We have it in English.
Hello. Say hello to the dentist. Sit on the chair.
People are doing it very slowly. Step again.
Switch on the right. Open your mouth wide. Say,
Then the picture exchange communication system. So this is Akshay, and his father is a software engineer. And he was the very first patient who came to us, and he was a real challenge. We didn't know how to treat. And this father and the parents were very, very positive, very helpful, and they were rather telling us about the methods. And this was, we went to the we resorted to picture exchange communication system. And these were the various pictures which were given to the child. See, we are giving all these to the parent. He's going to take them home. He is going to show it to the child. And a common terminology was developed together with his parents to describe the pictures. And then we use these words at home as well as in the hospital. Then the sensory aided dental environment, which is very, very calm, and it works on the Snoozlin principle. It is a very, we have dim lights over there, very calm music. Also the music therapy as well as the use of AV glass, that is also being used these days. Dental, and this, you can see this is a small modification which we have made in our clinic. Here also, the children have responded positively to this also. Patient in our clinic under nitrous oxide, because we find nitrous oxide wonderful. You can see the child. See, these are special. The LA is being a child. There is some amount of stabilization, yes. And this is Ahmad. And Ahmad, we can see how we are. पेन हो रहा है, कहाँ पे हो रहा है, हाथ लगा के बताओ, हाथ लगा के बताओ ना, कहाँ पे हो रहा है, हाथ लगा के बताओ, बता दें, पहले बता दिया, 10 तक काउंट करेंगे. First he was not ready, and slowly again he is 1, हाँ बस हो गया, 2, he is 3, 4, 5, हो गया. Let's do the treatment. See, now you can see he is so calm. And okay, is even after night. So this is how, you know, children. Obviously, in multiple settings, this kind of cooperation. But now in this it's all the work done. 2, 3. Okay. So concluding, I would say that the dental environment that meets the psychological and physical needs of the people with ASD and ADHD is very important. Inclusion of visual haptic elements as part of the behavioral facilitation before and during dental treatment is important. And adaptation of the duration of each treatment session to a suitable length for the patient based on the patient's age and expected stress levels may help us deliver the treatment even better. So April is Autism Awareness Month, I would say, and 2nd April is Autism Awareness Day, and October is the ADHD Awareness Month. So all of you should do something in your operatory and at your end to mark these days. Thank you so much for your patient hearing. I'm ready to take the questions now.
Dr. Anandaj, I think Dr. Kunal is there. He will take up the questions because ma'am had to go to National Dental Council for her first meeting. Okay. So Dr. Kunal will take care for all the queries.
So far, we don't have any questions in the chat box. Participants,
no,
if you have any.
No. Oh, it is there. How do we judge effectiveness of nitrous oxide sedation? Yeah, Dr. Kunal can take up this question.
Yeah, good morning, everyone. So, nitrous oxide can be used in patients with ADHD and autism spectrum disorder. Only thing is we have to, first of all, judge the anxiety level of the child, the age of the child, based on which we can decide whether nitrous oxide would be a suitable option for the patient or not. So the first decision has to be done based on just interaction, the social interaction with the child, whether the child is willing to come inside the operatory or the child is highly anxious. They don't even want to sit in the operatory and they just want to walk out of the clinic. So if the anxiety level is very high, then straight away nitrous oxide is not a good option for this children, and we have to explore other forms of behavioral management for this pharmacological approach for this child. Secondly, if we are able to establish some rapport with the child in the waiting area, we are able to bring the child into the operatory. So the most important, the critical step here is to desensitize the child. So it's very important that first we educate the parents that why we want to use nitrous oxide, what is the importance, how, what are we going to achieve, and also let them know that this is a technique where we can fail, and then we'll explore other forms of managing the child. And for which we just introduce the nasal hood to the child without attaching it to the tubings of the nitrous oxide machine, just to ensure or just to check if the child is accepting the nasal hood or putting something on the nose is acceptable to them or not. If they are able to accept the nasal hood on the nose without the tubings, and we do some counting, we'll just count till 20 and see if they can let the nasal hood be there for a few seconds. Then the next step would be to connect the nasal hood to the tubings of the nitrous oxide machine and start introducing nitrous oxide to the patient. So it's very important that we go stepwise, desensitize the child, and in certain cases we may have to go for rapid titration also, wherein we use a very high concentration of nitrous oxide straight away to reduce the initial anxiety, following which we can go ahead with the examination. So another important tip here is that in these patients, we should try and introduce nitrous oxide, because that would be much simpler than introducing many other sensory stimuli to the patient. For example, doing an examination which would involve putting things in their mouth or putting suction. So best is to first introduce nitrous oxide to these patients, reduce their anxiety, and then take them to the on the chair and do the examination. Along with this, all the non-behavioral, non-pharmacological behavioral modification techniques are equally important. For example, whatever has been discussed in the lecture, that is the lighting of the operatory should be dim. There should be minimum sounds around the operatory, minimum number of people or dental assistants in the operatory. We can have develop a snoozelen room in the operatory. So all these things will be beneficial for the child. Sometimes some tactile sensations, so giving those poppets or some stuffed toys or those squeezy balls, all these things are also helpful for the patient. So we have to not only focus on nitrous oxide, but many other forms of sensory stimuli have to be dealt with while dealing with these children.
Dr. Kunal, there are two more questions. One of the question is IV sedation an alternative for nitrous oxide? And also I'll plug another question along with this. If at all you're giving nitrous oxide for an obese patient, what are the things you should take into consideration?
So IV sedation, I would say the objective of using nitrous oxide and IV sedation is entirely different. So nitrous oxide is only an aid to our non-pharmacological behavior management techniques. However, if the anxiety level is very high and we want to do some short procedures like extractions or some simple fillings, then we can explore the option of IV sedation. Secondly, for IV sedation, our armamentarium, clinic armamentarium, need of personnel, that is, we need to have an anesthetist, good monitoring system, all those things should be in place. So the objective is entirely different whenever we want to explore IV sedation versus nitrous oxide. As I said, looking at the child, gauging the child, understanding this previous negative experience, understanding whether they are verbal or non-verbal, uh, taking into consideration their age, all these factors will help in judging whether the child will be fit for nitrous or we need other aggressive forms of pharmacological behavior management. So the history and just initial communication is the key to demarcate our path, whether we want to go towards nitrous oxide or we want to go for IV sedation. Secondly, the other question was whether we can give nitrous oxide in a child who's obese. Obesity is not at all a contraindication for use of nitrous oxide. So it's very much indicated in children who are obese, and we don't have to take care of we don't have to do any adjustments of concentration of nitrous oxide if we are administering it to an obese patient. So that's absolutely, there is not a problem for obese child.
So I think only this many questions are there in the chat box.
So is it IV sedation or oral sedation? Might be whether you can use the oral sedation along with the nitrous oxide.
Sorry, Dr. Anand, I didn't get your question.
Oh, no, so we can we use oral sedation and conscious sedation together? No.
Yeah, we can use oral sedation. So oral sedation can be used in children who are a little younger in age group and where we feel that they will not be able to accept the nasal hood. So for example, the child is able to walk into the operatory and he is able to at least, we are able to communicate with the child. We try and introduce nasal hood to the child, but we fail. The child is accepting, but only for 5 seconds. So if the child is not accepting nasal hood for good 20-30 seconds, that means the child will not be a good candidate for use of nitrous oxide. So in these situations, it's better to straight away plan for oral sedation rather than continue trying use of nitrous oxide, because that is going to build anxiety in the child regarding the clinician, regarding the operator, as well as the operatory and the entire environment. So we have to be very careful, mindful, and judicious where in these children when we want to decide which form of pharmacological approach we need to take for such situations. And supplementing nitrous oxide with oral sedation can be done depending on how's the response of oral sedation. So if we feel that oral sedation response is inadequate, then we can supplement with nitrous oxide for a limited duration of time.
Thank you. One more question. And is there any drug interactions what they are taking? No, they might be taking some mood elevators or some types of drugs they might be taking for the attention deficit hyperactivity disorders. So does it have any interactions with nitrous?
Yeah, definitely it has. There are interactions with the drugs which the child with ADHD or autism may be taking, and we'll be covering in detail about this aspect in module 2. So I'll talk about all the interactions and how to do dose adjustment of the oral sedative when the child is already taking some medication. We'll tackle that in detail in our module 2.
Thank you, sir.
Thank you, Dr. Kunal, for your answer.
Ramesh, there is one more question. Can you, Dr. Pooja mentioned.
What is the youngest age for which the nitrous oxide can be used? Dr. Kunal, one more question.
Okay, so all the questions are related to nitrous oxide now. Okay, so it's my pleasure to be here and answer all these questions. So actually, for nitrous oxide, there's no contraindication as far as age is concerned. It's totally dependent on the acceptability of the nasal hood. As a clinician, we should be able to judge that and appreciate the fact that a child who's younger than 3 years, their attention span is very short. So even if they accept the nasal hood, they may not be able to accept an extensive treatment. They may be able to accept a simple extraction. So if a child had a fall and we want to extract a maxillary central incisor, yes, for that child, we can go ahead and use nitrous oxide who's 2.5 years old. But if you want to do a pulpectomy in a child who's 2.5 or 3, then it's really difficult. So rather in my practice, I usually consider nitrous oxide for children who are older than 3.5.
Thank you, Dr. Kunal, for answering these questions in the absence of Dr. Mosmi. And I think the presentation was at par to excellence, and everyone were benefited regarding the management part of a child with autism spectrum disorder. Hope there are no other further queries in this session. So we would like to wind up the session. Thank you so much.
Can I have the certificate?
And secondly, Dr. Kunal will be there in Bangalore when we will have a physical module on this particular topic next month, which is on 23rd and 24th of April. So I'm sure all the delegates, all the attendees can get in touch with Dr. Kunal there and discuss all their queries, all their questions in person. That will be really great because he will be there for all 2 days. So you can catch him anytime there.
Thank you, sir. Thank you.
Can I have the certificate for moderators? Hello, can I have the certificate for the moderators?
Thank you, Dr.
Thank
Andraj.
you,
Thanks, Varinder
kindly,
sir. Thanks, ISPPD.
thank you, Ramesh sir. Kindly accept our certificate.
Yeah, thank you so much for this wonderful opportunity to be the moderator of this session. Thank you so much.
Thank you for your time, sir. So we'll move on to our last session of the forenoon session, that is on sensory disabilities, speech, hearing, and visual disabilities, and by Dr. Anshula Deshpande ma'am. So I call upon Dr. Anjana ji as our moderator and Dr. Santanu Chowdhury as our second moderator. Dr. Anjana ji is a professor and head of the Department of Pediatric Dentistry, Royal Dental College, Palakkad, with 27 years of teaching experience. Completed her BDS from AB Shetty Institute of Dental Sciences, Mangalore, and MDS from SDM College, Dharwad. Currently pursuing PhD at Sri Balaji Vidyapeeth. Active member of ISPPD, SAPPD, AK, APPDK, and IDA. Currently the executive member of ISPPD and president of IDA Greater Cochin Branch. Held multiple leadership roles, including the vice president, treasurer, editor, and chairpersons in IDA and APPK associations. Has 32 years of clinical experience with 35 national and international publications, contributing significantly to the pediatric dentistry. We welcome you, ma'am. Dr. Santanu Chowdhury is a professor and head of the Department of Pediatric and Preventive Dentistry, Government Dental College and Hospital, Ahmedabad. Completed BDS from GDC Aurangabad and MDS from SDM College, Dharwad, and also holds a PhD degree. Has 45 plus research publication in national and international peer-reviewed journals. Serves as editorial board member of multiple journals, including Journal of Indian Society of Pediatrics and Preventive Dentistry and reputed dental publication. Life member and serving as a joint secretary of ISPPD and member of Indian Dental Association. We welcome you, sir.
Thank you.
So over to you to introduce our speaker. Hello, sir. Kindly introduce our speaker.
Unmute yourself, please. Dr. Shantanu, are you introducing or Dr. Anjana is?
Yeah, I'll introduce.
Okay.
The speaker is a professor and chairperson at Shah Dental College, Sumandip Vidyapeeth, Vadodara. She is BDS and MDS from Manipal, MBA in clinical research. She has done several other degrees such as she has her interest in early childhood care is dental trauma and regenerative endodontics, special care dentistry, orthodontics, and educational innovation. She is a speaker at over 70 national and international conferences. And she's contributed to 8 textbooks, 60 postgraduate research projects she has guided, and she is a recipient of IADR Colgate Research Award, University Awards from various conferences. She is editor-in-chief of JIHS of ISP, supporting education, research, and academic initiatives. We welcome you, Dr. Anshula Deshpande, on this session.
Thank you so much, sir. And I'm very delighted for a well-conducted program. Again, a certificate course by Dr. Anand Raj, sir. And I congratulate Mosmi ma'am and Dr. Kunal Gupta for continuing this meaningful certificate course for all the ISPPD members. So with this, I would request the technical team to start my presentation.
Very good morning to one and all. And at the outset, I would like to congratulate all of you to join this yet another certificate course on special healthcare needs in dentistry, which has been very wonderfully directed and taken care of by Dr. Mosmi Goswami ma'am and Dr. Kunal Gupta. So as you know, the topic allotted to me is navigating the sensory disabilities. Rather, I would say navigating sensory abilities in dental care. Often we judge someone based on a diagnosis and we miss out on their abilities, beauty, and uniqueness. So this is what we have to keep in mind. People are not their diagnosis. So we have to respect their individuality. Based on this, we have to have an understanding that these children, they have unique abilities, and this sensory disabilities enhances certain different types of abilities in them. So sensory disabilities, deafness, blindness, and speech impairment require the use of strategies to improve communication using sign language, writing, use of braille, lip reading, and stimulating the sensor-perception of the patient's eyesight, touch, and hearing. While these individuals may not experience the same limitations as other patients, their needs are unique and require specialized, multidisciplinary oral health care. So conventional methods of dental treatment are not modified while treating patients with sensory disability, but we just use different management techniques to establish a more effective dentist-patient relationship. So with this, by now you all are aware that there is enhanced needs of these children with sensory disabilities and their families. Now just to quickly rush through what are the enhanced needs of these parents and families. First and foremost, financial cost. Second comes complex clinical management, behavioral and adjustment issues. And these behavioral and adjustment issues are not just with the child, but we have to take care of the parents because they are also going through a lot, and we can see and observe behavioral changes in the parents as well. Next comes the impact on families. Preventive treatment modalities are the mainstay because it can prevent many things becoming worsen, many diseases or pathologies become worse. Sixth is continuity of care. Many times I have observed in my last 2 decades of experience that many patients or parents discontinue the dental care. Then access to healthcare and linkage to school and community services are lacking, which may at manyfold help these children. So coming to role of parents, I feel the role of parents is of most importance in sensory disabilities as they act as a child support system. When a child is specially able, there is much that he or she does not understand. And when they are unable to speak, they cannot ask the questions what they desire to ask. So, thus, they are forced to depend on an interpreter, and mostly their parents are the big support as interpreter. Role of parents in dental operatory is also to make them understand. Before we have an appointment, we can schedule a pre-appointment visit just with the parents so that we can explain that what exactly will be happening in the next upcoming appointment. Another important aspect is positive methods of preparing the child for her first dental visit, and parents can play a good role. If possible, dental appointments should be scheduled so that the patient spends little time in the waiting room. The child and the dentist relationship is also very important, and in such cases, almost inevitably, the communication is affected. If an impairment or disability is severe enough that dentist and child cannot communicate verbally, then the dentist must use sight, taste, and touch to communicate and to allow the child to learn about dental experiences. So, as I initially said, that other sensory abilities are enhanced if one of the sensory ability is decreased or diminished. Many times, mild hearing losses or a young child with low field of vision are not diagnosed, which leads to management problems because of the child's misunderstanding of instructions. So it's not that it should be a deaf or a completely blind child. A hearing or a vision impairment also should be kept in mind. So children with severe sensory disability already have psychological and social disturbances that make dental behavior management more complex. And that's why we need to have an understanding of how to manage these children in the dental laboratory. So let us see what is the dentist's role. Oral health care needs of sensory disabled children are often overridden by the focus on their medical rehabilitation. However, with the current understanding of the fundamental role played by dental health team in the maintenance of general health of an individual, it becomes all the more important to provide access to dental services whenever it is mandated. Now, what are the goals of treatment? Yes, the goal of treatment is reducing the risk of developing oral diseases is as an integral part of the comprehensive oral health care for children with special healthcare needs. So whether it is neurological disturbances, sensory disabilities, medical conditions, comprehensive oral health care becomes an integral part, and hence the steps which incorporates anticipatory guidance, consent, treatment, recall, and transition of care when the patient reaches adulthood should be taken care of. So as you know, I'll be talking about sensory impairment. The three impairments which I am going to focus is hearing impairment, speech impairment, and visual impairment. Coming to hearing impairment, you all are aware of the anatomy of the earlobe, ear canal, middle ear, cochlea. So these are the various aspects of ear which gets affected, or there may be pathology to the any part of the hearing system. So are you listening? You have to carefully listen that the care for children with hearing impairment is important by the various methods to be used. But when we say hearing impairment, are you aware of the definition? The first terminology which was used was a deaf child, which no longer is used, and the term which we now use is hearing impairment, and based on the severity it is done. But a deaf child is one who does not have sufficient residual hearing to enable him to understand speech successfully, even with a hearing aid without special instructions. Coming to hearing impairment, disabling hearing loss means hearing loss greater than 40 decibel in the ear with a better hearing in adults and superior to 30 decibels in the ear with better hearing in children. So for adults, it is 40, and for children, it is 30 decibels. Hearing loss affects approximately 17 out of every 1,000 children and young people under the age of 18. So hence, the number is increasing, and that's why we have to have an understanding of how to manage these children in the dental clinic. So here you can see a total of 63 million people in India have hearing impairment, which is a common cause of disability, and that's why we need to have an understanding on types of hearing losses. Broadly, there are 4 types of hearing loss as stated by National Center on Birth Defects and Developing Disabilities, as well as Center for Disease Control and Prevention. The first is conductive hearing loss. Hearing loss which is caused by something that stops sounds from getting through the outer or middle ear. This type of hearing loss can often be treated with medicine or surgery. Second type is sensory neural hearing loss. Hearing loss that occurs when there is a problem in the way the inner ear or hearing nerve works. Third is mixed hearing loss, which includes both conductive and sensory neural hearing loss. And fourth is auditory neuropathy spectrum disorder. Hearing loss that occurs when sound enters the ear normally, but because of damage to the inner ear or the hearing nerve, sound isn't organized in a way that the brain can understand. And that's why the implementation and the action to this hearing is not observed in these children. Another way of describing is or categorizing is the first one being unilateral or bilateral loss, that is 1 year or both the ears. Prelingual or postlingual. By this, it means is the loss happened before a person learned to talk or after a person learned to talk. Symmetrical or asymmetrical, that is again both ears or different. Is it different decibel in the same in both the ears, or is it different in each ear? Progressive or sudden. So hearing loss worsens over time, then it is termed as progressive. And if it happens suddenly, then it is termed as sudden. Fluctuating or stable hearing loss, when it gets either better or worse over time, it is termed as fluctuating. And if it stays the same over time, it is termed as stable hearing loss. And the last type is congenital or acquired or delayed onset. Hearing loss present at birth is congenital, and if it appears sometimes later in life, it is termed as acquired or delayed onset. Now let us see how the conductive and sensory neural hearing loss occurred. So coming to etiology for conductive hearing loss, it can be because of earwax, fluid in middle ear from colds or allergies, middle ear infection, swimmer's ear, eustachian tube anomaly, ruptured eardrum, ear tumors, or congenital conditions. Few of them are treatable and can be managed. Few of them requires the treatment. Coming to sensory neural type, aging, illness like coronary artery disease, high blood pressure, stroke, or diabetes, ototoxicity, certain genetic conditions, being hit in the head or trauma history, noise-induced hearing loss, and congenital infections like cytomegalovirus are considered as etiologies to sensory neural hearing loss. Now we have talked about this. Now let us move on to the degree of hearing loss. First is mild hearing loss, where a person hears some speech sounds, but soft sounds are hard to hear. Moderate hearing loss is termed when the person may hear almost no speech when another person is talking at a normal level. Whereas severe hearing loss is one when the person hears no speech when a person is talking at a normal level and only some loud sounds can be heard. Profound hearing loss is when the person will not hear any speech and only very loud sounds can be heard, or maybe that also is not heard. So they are divided as mild, moderate, severe, and profound hearing losses. Now there are various investigations and diagnostic criteria which you should be aware of. And if you feel your patient is not responding well, you may ask them to go and get these investigations done. The first and foremost is history taking, a comprehensive history for the onset, duration, and progression, and nature of sensory impairment will help you to manage these children well in the operatory. Physical examination, focusing on the affected sensory systems, which are conducted by the auditory department. Neurological examination to assess reflexes, sensation, muscle strength, coordination, and other neurological functions. And then the fourth type of clinical assessment is functional assessment, which is evaluated to know the impact of disability on daily living activities and quality of life. Another ways to assess hearing impairment is audiometry, pure tone testing, and tympanometry, and autoacoustic emissions. In audiometry, they measure hearing sensitivity and ability to discriminate between sounds. In pure tone testing, it is the main hearing test used to identify hearing threshold levels of an individual, enabling to determine the degree, type, and configuration of hearing loss, and thus providing a basis for diagnosis and management. Tympanometry is to evaluate middle ear function and eardrum mobility. Autoacoustic emissions assesses the function of the cochlea, and if the cochlea is having a defect, usually the cochlear implant surgery is advocated. But here I would like to highlight that hearing loss also affects speech and language skills. When a child has difficulty in hearing, the areas of the brain which are used for communication may not develop appropriately. This makes understanding and talking very difficult, and that's why those children who have hearing impairment, they have speech and language or communication difficulties as well. So when we talk about speech or language impairment, here we see that there is an impairment of speech or sound production, fluency is affected, voice or language, which significantly affects a child's educational performance or his social, emotional, or vocational development. So for most children, learning to communicate in the native language is a naturally acquired skill whose potential is present at birth. Novel development of speech and language is predicted on the infant's ability to hear, see, comprehend, and remember. And that's why the children with visual and hearing impairment, they found difficult to have a good communicative skill. So it is equally important and has sufficient motor skills to imitate oral motor movement and the social ability to interact with others, and hence their communicative skills improves. So let us now classify the phonatory system which is involved. Usually the disorder of voice, which is termed as dysphonia, are impairments often occurring due to physical reasons such as involvement of the larynx. Second type is speech sound disorders. It involves difficulty in producing specific sounds such as s, r. Phonetic disorders, which are also termed as articulation disorders, where the child will have difficulty in producing sounds physically. Phonemic disorders, where the difficulty in learning to distinguish the sound is present. Dysarthria is a damage of nerve leading to weakness or paralysis of speech muscles. And then there is a disorder of frequency, where the frequency is adapted or is received by the brain, but there is a delay in processing it and implementing it, and that's why these disorders are commonly seen. Now, in disorders of frequency, again, they are divided as 6 types, as apraxia, stuttering and cluttering, which is usually confused as one, but there is a difference between the two. So let us see what are these disorders of frequency? Apraxia of speech can result from STO or can be developmental in origin. It can be recognized by inconsistent production of speech and reorganizing of sounds in a word. Stuttering is primarily characterized by repetition of sounds or words, often accompanied by physical tension. Whereas cluttering involves speaking too quickly and rapidly, which results in disorganized speech with potentially mumbled or slurred words, often without noticeable physical tension. Dysprosody is a rare neurological speech disorder which is characterized by alterations in intensity, in the timing of utterance segments, and in rhythm, cadence, and intonation of words. Muteness, it is complete inability of a person to express verbally. That's why deaf and mute are the terms which are used for these children who are completely, they cannot hear or they cannot speak. The various etiologies are correlated to functional, organic. In functional, it can be due to environment, psychological development, habit, or due to intelligence. Organic, which has structural variation. Primary organic voice disorders are due to asymmetry of vocal fold, neuromotor disorder, trauma to vocal fold, or any cyst, polyp, or senile atrophy. Secondary organic voice disorders are mucosal irritation, recurrent laryngitis, chronic hypertrophic laryngitis, which are for a certain duration and which can improve. Now, when we talk about speech impairment, for dentists who treats these children should be familiar with physiology of speech and the means of correcting speech defects. Many of the dental or speech pain physiologies may be prevented, corrected, or minimized when the dentist and the speech pathologist work together. The dentist needs to be aware of the linguistic, physiological, social, and educational implications of normal and abnormal development of speech language, and that's why it's a teamwork which will help to minimize the issues well. So, in an overview, at a more abstract level, verbal skills include the ability to link thoughts in a coherent way. It is customary to divide language and communication skills into two. First is receptive, and the second segment is expressive. In receptive, it is related to hearing and understanding, and then expressive is what they do is by talking. Child's cognition development relies mainly on the development of speech and language, which is in the Broca's area, which has the functions of speech production, facial neuron control, and language processing. So if this area is affected, then it will be a congenital defect for the child to have this effect. Now, let me show how the speech comprehension and the psychological problems are correlated with the disability. As per the decibel based on ISO, if it is 0, that means disability is insignificant, little or no difficulty in speech comprehension, so there will be no psychological problem. But if there is a hearing impairment, which is slight, then difficulty with faint speech, language and speech development happens within normal limits, and child may show a slight verbal deficit. Whereas if it is mild to moderate, frequent difficulty with normal speech at 3 feet can be observed. Language skills are mildly affected. Psychological problems can be recognized in mild to moderate disability. If it is marked, that is 55 decibel, then frequent difficulty with loud speech at 3 feet, difficulty in understanding with hearing aid in school situation. So these children are likely to be educationally retarded with more pronounced emotional and social problems than compared to children with normal hearing. If it is severe, may understand only shouts or amplified speech at 1 foot from ear. The prelingually deaf show pronounced educational retardation and evident in emotional and social problems as well. But if it is extreme, usually no understanding of speech even when amplified, then child does not rely on hearing or communication. So the prelingually deaf usually shows severe intellectual disability and emotional underdevelopment, and they will require more care and training for the dental appointments as well. Now let us see the dental conditions which are associated with speech impairments. The impairments associated with speech and language can be primary, lacking the specific cause for the impairment, or secondary, where the impairment is due to other conditions or syndromes such as Down syndrome, mental retardation, anatomical defects, tongue-tie habits, hearing loss, or many times due to early childhood caries when there is a multiple loss of teeth, it may affect the phonetics. So dental associated defects, speech defects can occur either due to faulty dentition or sometimes an already existing speech pathology. In cleft lip and palate patients, we see due to malocclusions and other defects. Jaw alignment, prognathic mandible can affect tongue tip placement that ultimately results in tongue plate realizations, and hence the speech defect can be observed. So malocclusions, like gastric malocclusion, causes around 50% of severe articulation deviation. In crossbite and open bite, which causes interdental production of alveolar sounds like sir, sh, z, th, third of are affected in anterior open bite. Overbite can affect tongue tip sounds. Anterior spacing, all dental sounds except na and ya are affected. High palate, sa, za, tha, la, ka, ja are affected. And in narrow palate, sa and za, tha are affected. So one should be aware that these malocclusions can also affect in the speech. So what are the investigations for speech impairment? There are standardized tests for language. The analysis and documentation of scores from comprehensive, standardized, receptive and expressive language tests are done. It should be at least 2 standard deviation below the mean for chronological age or a percentile rank of 2. So assessment in the areas of morphology, syntax, semantics, and pragmatics through various analysis and documentation of standardized language is carried out. Observation and informal assessment in these areas when standardized instruments are not available. So for children with a delay of 1.5 standard deviations in language, either receptive or expressive, a cognitive or intellectual abilities assessment is also required. Because many times if they have any intellectual disability, they may not be showing a language reception or expressive aspects. So the following tests can be used to help and diagnose speech disorders. These 3 are Denver Articulation Screening Examination, Early Language Milestone Score, and P-Body Picture Test. So the DACE, that is Denver Articulation Screening Examination, is a 5-thread test that assesses a child's pronunciation of words, used to diagnose articulation disorders in children between 2 and 7 years old, and it is a developmental screening test that also assesses communication, motor skills, problem solving, and social skills. Whereas Early Language Milestone Scale 2 version 2, it is a test that helps identify language disorders and delayed speech in children. It is created by neurodevelopmental pediatrician James Copeland, and that's why many pediatricians are using this scale. The third, what I mentioned, was P-Body Picture Vocabulary Test. A revised version of this is available. It has been revised many times since its first version, which came in the year 1959. It is a test that assesses a person's vocabulary and ability to speak. It involves listening to words and selecting pictures that best describe them. So the treatment for speech disorder varies depending on the type of disorder and may include speech therapy. So let us see what are the goals for management. First and foremost is to develop their communication skills, to stimulate their alternate communication skills, enabling them to compensate for missing skill. So we can use writing skill or ability to pen down emotions in the form of painting and sketching, to help making them expressive so that they can establish direct communication and be independent, thereby eliminating the need of mediator. The fourth goal is communications management may include one or more of the following types of essential therapy: speech therapy, behavior therapy, environmental modifications, be a good speech model, consult a speech language expert concerning each child with the communicative problems. So here you can see a speech therapist. We have a speech therapy department in our university, and this is how a speech therapist teach them how to pronounce and develop speech. So you can see the speech therapist is in front of the child, and the child is observing the oral musculature movement, and then he is able to make the sound. So let us now move on and see what are the modifications in behavior guidance and communication strategies for hearing, speech, and communication disorders. These children have difficulties communicating with the dentist or nurse and understanding what will take place during the appointment. So the child preferred means of communication should be known by the team. For many children, simple measures such as removing masks and reducing noise may be sufficient. Next aspect is to establish communication. Explain complicated procedure by various means like drawing or ready videos or manuals. Check if your communication is working. If not, change your way of communication. Ask questions to understand if patient is able to comprehend. Make sure the interpreter is present at all the appointment. Use facial expressions effectively as they are the non-verbal form of communication. Another foremost important thing is that if your child is wearing a hearing aid, ensure adjusting so that you eliminate or minimize background noise during the conversation. Avoid sudden noises and putting your hands close to the hearing aid during the treatment, because when you place the hand during the treatment, there is a buzzing sound which is felt. The child may want to adjust or turn off the hearing aid during treatment, so inform them before you start to use dental equipment, especially the aerator handpiece. In behavior modification strategies for language and communication, augmentative and alternative communication systems are being used oftenly in these children. They can be divided as unaided and aided. In unaided, sign language is used, whereas in aided, picture-based communicative system is used. And nowadays, I have been part of Akshar Trust, which treats and has only hearing speech impairment children. And they are using picture-aided communication system, which is helping them a lot to train these children. Unaided sign language, nearly a third of the patients needed special communication techniques like sign language. So all dentists should learn simple sign language and principles of communication with those who have hearing impairment, or you should have someone as an interpreter or from the parents in the operatory so that a better communication can be established. So these are the various basic sign languages which you can take printout or have a copy with you so that you can start communication with these children. Coming to picture based, so open mouth models, to know their response after your treatment, no hurt. So based on emoticons, you can use this aided communicative system. So presently, aided picture-based AAC systems are used more frequently and successfully with individuals with ASD than unaided system due to a match between the characteristics of ASD and the ease of use of such systems. In several early studies found that difficulties in imitation may be one reason manual signs are difficult for people with ASD to use and understand. So we have to see that many times these speech and communicative issues are not just purely speech impairment. It is always combined with other problems also. The picture exchange communication system, which is in short also termed as PECS, is a way for children with sensory disabilities to communicate without relying on speech. So to communicate, people use cards with pictures, symbols, words, or photographs to ask for things, comment on things, or answer the questions. So these are the various examples of picture exchange communication: cavities, clay impression, special picture of your teeth. So all this should be mentioned in the picture and in the wordings. So here you can see a dentist displaying pictorial flashcards to children who will receive dental treatment. Visual aids such as illustrated brochure or a child's book descriptive of first dental visit are helpful in painting a realistic picture. So storybooks, all these things can be used for these children to make them better understand. Use of facial expression and hand sign to communicate. Show, feel, do technique for these children is used. Tell, play, do technique for children with speech and hearing disabilities. Auditory verbal therapy with guided imagery for speech and hearing disabilities. So here you can see it is usually combined. You can see this child has an implant. So with the help of imagery. And you can see here how the teacher, speech therapist, is pronouncing near the ears so that he can feel the sound and the air which comes out from the mouth, so that they can have a better understanding of how the speech should be there. These are another cases, the patients who are being trained at our setup by speech and auditory therapy department. This child, after having the treatment and the management for the hearing impairment, how he is learning the speech and the speech therapy is taking place. So you can see here the lot of picture exchange method to train these children, which are being used for developing communication skill in these children. Another method is draw and tell communication. Use of drawings increases the amount of information that children share. Using this communication modality in a child who cannot express verbally can make them experience in operatory meaningful, relevant, and orienting in their dental procedure. So through listening the description of drawing, we can appreciate how the experience of fear can unmake a child's world and sense of power in relation to it. So here you can see this patient, how children with sensitivity typically know more than they can express. So reports suggest that the brevity of their responses might actually relate more to their inability to retrieve information than to their understanding of the event or concept under question. So this child always wanted to do drawing before any treatment started. So here you can see again, this child now is drawing and expressing his understanding. Another interesting mnemonic has been given by the authors as quoted here for dental management, which is I stumbled, where I is images, S stands for sign language, learn it, traumatized, so they understand that they are traumatized, unaware, understand that they are unaware of the consequences of the dental problems, models, use them, breaks, give breaks, lip movements, stress on lip movements while you are communicating with them, be enthusiastic and use desensitization for these children to manage in dental operatory. So you can see here, in nutshell, evaluation should be made regarding their disability and assess the level of impairment. Make use of non-verbal communication. Use audio-visual distractions. Pen, pencil, and notebook should be handy for these children to convey his doubts and queries. Make sure that child's vision is not hampered and not obstructive at all times, because what they view while you are talking is very important, and that's how they comprehend. Well-lit clinic so that the child's visibility is maintained. So these are the basic important aspects pertaining to hearing and speech impairment. Now let us move to treating children with visual impairment. Vision is one of the primary senses that help a child constitute his or her environment during the early years of life, the absence of which may have damaging effects on their overall development. So low vision is defined as visual acuity of less than 6/18 equal to or better than 3/60, or a corresponding visual field loss to less than 20 degrees in the better eye with the best possible correction. Whereas blindness is defined as visual acuity of more than 3/60 or a corresponding visual field loss to less than 10 degrees in the better eye with the best possible correction. So this is very important to understand that an estimated 253 million people live with significant visual impairment. All those who are wearing lenses or glasses, we are also actually visually impaired. But with the correction, that impairment is minimized. So 36 million are blind and 217 million have moderate to severe vision impairment. So most of these people reside in South Asia, East Asia, and Southeast Asian countries, and that's why for us to have an understanding of these children becomes important. According to WHO, they have classified them based on the level of their vision. First is normal vision, where visual acuity ranges from 20/10 to 20/25. Near normal vision ranges from 20/28 to 20/60. Moderate visual impairment ranges from 20/70 to 20/160. And severe visual impairment ranges from 20/200 to 20/400. There are many causes of visual impairment like albinism, cataract, cerebrovascular events, cone rod dystrophy, congenital dystrophies, cytomegalovirus retinitis, diabetic retinopathy, glaucoma, keratoconus, malignant myopia, various syndromes, nystagmus, optic nerve hypoplasia. So these are the various common causes of visual impairment. Some are treatable, whereas some are not treatable. Coming to oral health status of visually impaired children, many studies have stated that these children have higher incidence of caries, periodontal and gingival diseases, as well as traumatic injuries are observed commonly. Al-Alawazi reported that the blind subjects in his study had increased predisposition to traumatic injuries and poor oral hygiene. So, oral health status of these visually impaired children becomes the primary reason for such poor oral health status as their inability to visualize early signs of dental disease. That's why the role of caretakers and establishing dental home for these children becomes very important. In addition, some children with visual impairment exhibit limited hand-to-eye coordination also, and hence for brushing by these children becomes a little tough. Coming to behavior guidance modification, we have a few of things that is difficult to understand or see. That's why we see that problems in issues in these children also, which may adversely affect their attitude towards dentistry. So that's why play, tell, and then do is very important way of behavior management. So their fears and attitudes towards dentistry is often reflected in their behavior in the operatory. Thus, a combination of techniques customized according to their individual needs should be utilized. Communication can be verbal or non-verbal. It is not just what the dental staff says, but the way they say is also important. It is often the tone of their voice that makes an impact on the child. So it's not what you said, it's how you said it is important for these children. In these children, audio tactile performance technique becomes very important and is very helpful. It is a multisensory health education method that is specially designed, is a very effective communication tool to educate children with special healthcare needs. And similar study was done in our department, and we created this chair model which had air, water, and a dental chair prototype so that we can explain them with these visually impaired children with audio tactile method, and we saw that the acceptance of the chair and the movement of chair was much better in these children. Now, certain modifications should be done in the dental operatory. The first is for the physical access. Elevators should have numbers in braille. Adequate space for mobility devices such as walkers and canes. Accessible restrooms for these patients should be ensured. So this is American with Disabilities Act has passed, which where all the elevators should have brailles and raised numerals so that it is easy for them to understand. Nowadays, facilitated guide dogs are being used, and they can be used to provide better access to dental facilities also. Reducing glare becomes very important. Lighting should be of sufficient clarity to enable the dentist to see materials and to perform necessary visual tasks. Depending on the patient's visual needs, lighting may need to be increased or decreased. So you should always ensure that in your operatory, if you have four lights, you should be able to switch on few of them. It should not be a one switch operatory lights. Any extra light should be diffused and indirect in order to minimize glare for these children. Coming to dental management, determine the degree of visual impairment. Always ask if patient desires assistance. Encourage parent to accompany child. Describe clinic vividly and every procedure and instrument so that child can paint picture in their mind. Allow the patient to ask questions about treatment. Allow patient to wear eyeglasses for protection. Use touch, taste, smell. Avoid side references. Use audio cassettes and braille dental pamphlets to explain procedures where available. Keep distractions to a minimum and avoid loud noises. Explain the smell of the material before placing it in oral cavity, as they have alternative heightened response to smell and touch. Provide treatment in the same location and by the same team at all the times possibly, so that it is easy access for them and the environment doesn't changes, which will reduce their anxieties. Letting patient feel the instrument with assistance leads to better acceptance. Motivate them and teach them correct brushing technique. Discourage self-inflicting habits as they are very in traumatic situation. So here you can see a pre-treatment communication, parental presence in the operatory, audio distractions with soothing music, motivate and teach correct brushing technique using models. Certain modifications should be also carried out in dental operatory with the help of common assistive technologies for the visually impaired. So this encompasses print and auditory information before, during, and after the appointment. People who are blind or low vision need alternative formats for written communication, including large print or braille written information, image descriptions, and audio email information in the accessible formats. So Alexa, Siri, Google Dot are voice activated tools. Those who are blind or visually impaired can use it for tasks such as making appointments, checking on the calendar, and nowadays mobiles also have voice commands. This is another study which we have done where we have used this breathing so it has movement and the sound also. This is given to the child to understand. And then it is turned towards the child to give them comfort, breathing, and the sound so that such aids and toys can be used for your dental operatory to make them feel comfortable. Reading assistants like various screen readers work with Windows operating deals. So to impart dental education and oral hygiene information for these children, it can be utilized. Auditory access devices, you can audio record the health education and share with them. Now coming to definitive treatment for the visually impaired. A thorough medical and dental history along with consultations with their physician is mandatory to obtain an insight into the case management, aid in planning, and to avoid unwanted complications. It is critical to establish the degree of visual impairment so that information and treatment can be tailored accordingly. Scheduling appointments. The treatment planning should be done well for these children with sensory disabilities. There is no room for shortcuts, as the difficulty in reporting for repeated dental appointments needs to be considered before addressing a specific dental problem. An effective preventive protocol should encompass diet counseling, oral health education, adequate fluoride application, placement of preventive resin restorations and sealants, followed by regular recall and follow-up appointments. This is all the more crucial as these children cannot visualize the predisposing factors as well as the early signs of dental disease. So methods can be custom designed according to individual patient needs and at the same time stay rooted to the basic principle. When I talk about first dental visit, you should demonstrate toothbrushing, flossing, and tongue cleaning. Numerous education aids in the form of models, rhymes, brails can be used to teach them. For deaf or visually impaired, demonstration and explanation will be very beneficial. The dentist should demonstrate for the deaf child all the instruments and equipment, that is, the air, water spray, the moving toothbrush, and other things, so that they are accustomed to various equipments in the dental chair. The parents are positioned in order that the patient can easily view them. The parent is visible for interpretation and reassurance for hearing impaired children. Preventive dentistry, actual dental treatment for visually disabled children closely parallels that performed with hearing children. So daily home care measures have to be ensured and emphasized for the parents. Coming to restorative dentistry, it is often difficult to explain the concept of local anesthesia to a sensory impaired child prior to initiating restorative procedures. So once the local anesthetic has been administered, it is imperative that the dentist be absolutely positive that it has taken effect. In cases observed where restorative procedures have been performed without complete anesthesia, the child has often regressed in behavior, feeling betrayed, and occasionally has become a management problem. So the use of rubber dam during restorative procedure may also risk negative behavior patterns. In the case of a deaf child, the close proximity of rubber dam and holder to the patient's eyes may threaten their area of communication, perhaps causing an adverse reaction. So ensure that the vision is not affected. It is always beneficial to perform pulpotomies or pulpectomies rather than less reliable pulp capping procedures. Full coverage restorations should be opted for, and fluoride releasing materials are useful as both preventive and therapeutic approaches in these children. It has been reported that visually impaired children are prone to anterior teeth trauma, and the risk factors primarily include an increased overjet or inadequate lip coverage. So this necessitates the identification of these risk factors and timely intervention in the form of early orthodontic treatment. Now coming to treating children with sensory disabilities under general anesthesia, GA is an efficient and safe resource for patients whose special characteristics make it impossible for treatment to be performed under local anesthesia or conscious sedation. It is observed that the use of GA is increasing in this patient profile as the preschoolers under the age of 6 with sensory disabilities lack the emotional and psychological maturity needed to tolerate extensive dental treatment. But the need for pharmacological behavior management under general anesthesia should be evaluated well, because you should not forget that dental problems can place an additional burden on children with special healthcare needs. All of this highlights the need to consider children with special needs a high priority group and to take into account the risk of developing oral diseases that require more extensive preventive and treatment care. So indications for the choice of GA should be based on specific criteria. You should evaluate the risks, benefits, efficacy, and expected results. Need for pharmacological behavior management under general anesthesia has to be well evaluated before you take the patient for GA. So need for pharmacological behavior management under general anesthesia. Remember that behavior guidance techniques as an alternative should be preferred prior to considering GA for these patients. And with this, I would also like to emphasize non-discrimination in access and clinical decision making. Now here I'm not talking about access to the dental or medical treatment. Here I am talking about there shouldn't be discrimination between choosing the treatment option for these patients. The clinicians who care for patients must not let medical status define their access to the dental procedure. Whatever is best should be provided to these children. So some of the most wonderful people are the ones who don't fit into the boxes. We have no special needs children, just children with special needs. So this is a most, I really like this quote given by Rolf Maurer that these are the just children with special needs. Now quickly I will show you a few cases where I want to say that dental care and modifications to adaptive and communicative behaviors are possible with the use of early and intensive therapies by reconstructing and combining behavior guidance therapy. You can see here, this is a patient named Aisha with medical history of pontocerebral hypoplasia. So she used to play this toy, the sound, and that's how the audio distraction helped us to examine this child. Another child, how to establish communication with children visually impaired. One of the eye had cataract. So here you can see we are using fidget, a spinner, to communicate, and then this child is cooperating and we are used, extraction was done, and this is the cementation of band and loop which is being carried out. So you can see here how the child has been given this model to play so that he is distracted. This is another case, a 9-year-old girl with speech and hearing impairment. The examination was done, extraoral swelling was found, and there was a cyst, bulging of the cortical bone with pain and mobility of the teeth in the same region. Extraction with curettage was performed for 8-5 and 7-5, and the cystic lining was enucleated. This is a radiograph of 1-year-old follow-up, where the premolar was, so the radiograph showed root development of. Now here, while treating this child, it was really tough to give local anesthesia because the effect of local anesthesia, the block, the child was not able to understand. Then we called the mother in the operating to help and assist us to communicate with the child. This is another case where the child was having epilepsy along with developmental delay and partial hearing loss. So showing these patients and doing the treatment with each and every step with show and do was very important. Another case where cerebral palsy with nystagmus, hypertonia and hyperflexia in upper and lower limbs was seen. The muscle power was 3 out of 5 in all the limbs. And though the parents were ready for GA procedure for full mouth rehab, but the GA was denied, and hence this patient was taken up with GA. In such patients where mobility is tough, you can use mobile portable X-ray unit for radiographs, and the introduction of patient to noise apparatus was carried out, and it was seen that the patient was cooperative for this. But though this patient was cooperative, but for parents coming often for the dental treatment was tough, and after few appointments they discontinued the treatment. Another case, the child, 10 days old female baby born with corneal ulceration leading to cataract in right eye with retinopathy. Here, the appliance, preoperative cleft and soft and hard palate was a feeding plate was delivered. And this is the mother's feedback that the child has improved on feeding and she is happy. So let us just quickly see the stages of how to manage. The first and foremost is pre-appointment preparation. Communicating with your dental team. It's not just that you have to communicate with the parents. You have to also communicate with your dental team. In-office strategies have to be planned so that you have all the various aids while treating these children, creating a sensory-friendly dental environment, and post-appointment self-care strategy. So these are the 5 strategies which a dentist should think of in their dental operatory. So to summarize, a knowledge of etiology and consequences can be an invaluable support for the dental personnel. Be aware of the psychological aspects of the child's disability and their dependence which the child has on their parents. When the dentist understands these aspects, you will be attuned to the situation which they are being facing and you will be able to close the communication gap. Complete confidence is gained by the patient. The dentist will discover that performing dental care for these children is the most rewarding and satisfying experience. So I would like to end with saying, if a child can't learn the way we teach, maybe we should teach the way they learn. Thank you for making a difference by joining this course, and I wish you all the best.
Thank you, Dr. Anshula, for elaborating about this different kind of speech, hearing, vision disabilities, and how to manage them. Actually, screening of the speech, then hearing and vision problems during history and examination are very important for early referral to appropriate medical consultants. Similarly, modification in of the communication methods can also be adapted according to the cases, such as simple language is also might be useful in certain cases, pictures, audio, then braille, models, then touch guidance. That you have already mentioned all these things. It is really very important to implement all these things in our day-to-day clinical practice of the patients, for the patients having these difficulties. We have to plan for individual patient. That is, individual planning is very important for prevention oriented care for children with sensory disorders. Thank you so much for such elaborative approach and thrown some light on this, I think, ignored aspects of special health dentistry. Thank you so much.
Thank you so much, sir. And I feel privileged that my session was moderated by you and Anjana ma'am. Thank you so much, sir.
Thank you, Anshula, for that complete and comprehensive management tech strategy for children with speech and hearing and visual impairment. Many times, like you said, children with mild visual and hearing impairment goes undiagnosed. And we actually will be able to identify that because we interact with children so closely. Thank you. I don't think there is any questions so far. If anyone has questions, I think it was too comprehensive, I guess.
Yeah.
Maybe they are tired from the morning, they are listening.
No,
there are only 2 options.
Very
Either they have understood everything or they are too tired. Anyways, you all can connect later on also with me and any of the experts associated if you have any queries. Thank you, Anjana ma'am. Thank you, Shantanu sir. And thank you, Anand Raj sir, for hosting this event.
Thank you, ma'am.
Thank you so much.
Thank you.
Can I have the certificate for the speaker?
Dr. Anshula, please accept the certificate on behalf of ISPPD for such a valuable and informative lecture for all of us.
Thank you, sir. Thank you so much.
Can I have the certificate for the moderators? Thank you, Anjana ma'am, for being with us. Thank you, Santanu sir, for being with us
Thank you so much.
and your valuable insights into it.
I'm so thankful to ISPPD for giving us this platform. Thank you so much. It has been conducted so excellently, and I have been watching the sessions going on. It is very excellent way of conducting online sessions. Congratulations to you also. It would be little earlier, maybe, but still, I wish to congratulate you for this and your team, entire team.
It's more important, sir. The team, the tech team is more important. Yes,
True.
they are the ones who are working behind.
Yeah.
Thank you, Dr. Anshula. Thank you, Shantanu sir. Thank you, Dr. Anjana. And
Thank you, sir.
Thank you, sir.
Bye.
Thank you,
Goodbye.
sir. Thank you.
Meet at 2 o'clock now.
Yeah, so with this, we are ending the first session. We'll meet at 2 p.m. sharp. So kindly join 1:55 so that we can go on time. Thank you all for being with us. So catch you later. Bye.